Welcome. My name is Lisa Dubé. I'm a senior fellow at the Urban Institute in the Health Policy Center. Many of you know the Urban Institute. It's a nonprofit research organization that provides data and evidence to help advance upward mobility and equity. I also co-direct the National Coordinating Center for the Policies for Action program, which is a signature program of the Robert Wood Johnson Foundation. Since 1915, we've made about $43 million in research grants to identify policies, laws, and other levers that can be used to advance health equity. Today, we're going to draw on some of that work, the great work that P4A researchers have done over the years, and we're going to talk about advancing maternal health equity and how research, policy, and advocacy can inform solutions. So last week, I was reminded by an email from RWJF about what Heather McGee tells us in her book, The Sum of Us, which is that if we lift a barrier for the most vulnerable among us, we improve the health and lives of all of us. And that's what we're going to talk about today, some ways in which we can do that. I'm excited about having this event here at the Urban Institute because of our long history of working on the central role that Medicaid has played in promoting maternal and child health. This work began in the late 1980s, and we showed, when we showed how the Medicaid expansions for pregnant women improved access to prenatal care and birth outcomes for low-income pregnant women. Our research has shaped policy. Most recently, we documented the number of women who remained uninsured after birth and the importance of Medicaid coverage after delivery for addressing maternal depression and mortality. This research provided evidence that helped encourage the Biden administration to allow states to extend Medicaid coverage from 60 days postpartum to up to a year postpartum. As of today, all but 2 states have taken up this option. And we focused on the best ways to provide care to Medicaid-covered pregnant women. Under a Center for Medicaid and Medicare Services evaluation, we showed that birth centers that followed the midwifery model of care reduced the rate of low birth weight and the cost of care for Medicaid-covered patients. And through other work, we've described the power and limitations of racial concordance between providers and pregnant women and the potential ways we can increase the diversity of the maternity care workforce. As many of you know, Medicaid is a critical program for low-income pregnant women. It provides insurance coverage for about half of the births in this country. But as I stand here today, at the end of a week when the House Republican leadership passed a budget resolution that requested $88 billion in cuts from the part of the federal budget that includes the Medicaid program and $230 billion in cuts from the part of the budget that includes the Supplemental Nutritional Assistance Program, or SNAP. Urban researchers, Policies for Action researchers, and many others have demonstrated the importance of these programs to the health of pregnant women and their children. At the same time, the past few weeks, there has been a gutting of programs designed to improve the health of people in communities who have been marginalized by structural racism and classism, or because of their sexual orientation or gender identity. So we're at a unique moment right now. So today, we're going to talk about the evidence about what works and what needs to happen to lift some of these barriers and improve health equity among pregnant women. And we have 3 great panels to do that. Our first panel, we're going to talk about how increased access to maternal care affects outcomes in different communities and what policies are needed to meet the needs of different groups of pregnant women. In the second panel, we'll talk about bridging gaps in maternal health, and we'll share perspectives from community, research, and policymaking. We'll talk about how where you live matters and what that means for policymaking designed to reduce disparities in maternal outcomes. And we'll also hear about 2 innovative solutions designed to improve the care and outcomes of pregnant women. And our final panel, Turning Grief into Action, Black Fathers Seeking Solutions, we'll hear from two fathers who are taking on maternal and morbidity and mortality crisis in America by elevating and engaging the voices of spouses and fathers on this issue, developing community-centered solutions, and using art, film, and music to spread greater awareness and activate mass audiences. So with that set up, I want to talk a little bit about some housekeeping items. So this event is being recorded, and the recording is going to be posted online afterwards. There are speaker biographies and slides that are available online. If you're out there in the virtual audience, you can type your questions into the form that's shared in the chat. And then in-person attendees can use the QR code to submit your questions. And because we always like to know how we do, please complete the survey at the end of the event. So without any further delay, I'm going to ask our first panelist to come up. I'm going to have each of you introduce yourself when I ask you a question, but we have a great panel here. So, before the Affordable Care Act was implemented, most states covered pregnant women up to 200% of the federal poverty. But a lot of that coverage didn't happen until either you became pregnant or it ended right after, 60 days after birth. What the Affordable Care Act did, and what people were excited about, is it provided the opportunity to improve the preconception health of moms, to provide greater access to comprehensive contraceptive care and potentially improve intendedness of births, and also provide greater access to prenatal care, more timely and comprehensive care. We know from the research that there were many improvements along all of those dimensions through research that Policies for Action researchers have done, some of you all have done, but we also know that there are still many disparities that remain, and we also know that the Affordable Care affected different populations of pregnant women differently. So I'm going to ask you all to talk about your research that you've done on this topic, and I'm really excited to share with the rest of the world what you all found. So I'm going to start with Julia, and you can introduce yourself as well.
Okay. Hi, everyone. Thank you for having me here today. My name is Julia Interrante. I am an epidemiologist and health services researcher by training. I am a research fellow, and I really focus on data and statistics for measuring and studying maternal health and healthcare access, as well as looking at care before and after childbirth.
So your research looked at maternal health care among Hispanic women, both by primary language, but also according to state policies. Can you talk to us a little bit about what you found?
Yeah. So as I mentioned, a lot of maternal health research focuses on what's happening during pregnancy and childbirth, but what happens before pregnancy and after birth is also really important. We know that the health status before pregnancy can really be determinative of birth outcomes, and that half of all maternal deaths happen after childbirth. And that healthcare visits during those periods before and after birth are important to find, prevent, and treat issues, and insurance can help pay for those visits. So Hispanic women have higher rates of hypertension and diabetes and other factors that can increase risks in pregnancy and childbirth. And we also know that language and not having English as your primary language can increase challenges around knowing what type of insurance that you are eligible to sign up for, and also could make it more difficult while engaging in the healthcare system. So we use data from PRAMS, which is the Pregnancy Risk Assessment Monitoring System, that surveys moms 2 to 6 months after childbirth. And it is a survey conducted by state and local health departments in collaboration with the CDC. And so we looked at Hispanic moms who had given birth between 2016 and 2020. We looked at, again, what if they had visits before, during, and after childbirth, and also wanted to look at what happened during those visits. So not just did they have a visit, but did they get the recommended screenings and content and counseling during those visits to improve maternal health. So what we found was that Hispanic moms who primarily spoke Spanish were less likely to have a visit prior to pregnancy, and that they were also more likely to start prenatal care later in pregnancy, which is associated with worse health outcomes, and also have less than the recommended number of healthcare visits. But when they did have visits, they were more likely to receive more of the recommended screenings and content at those visits than their English-speaking counterparts. So again, we also found that the state Medicaid policy environment impacted some of the gaps that we see by language, but only for some of the measures that we looked at. Increased eligibility for Medicaid did play a role in decreasing some of those language gaps for things like the number and timing of prenatal visits, as well as the number of screenings received at postpartum visits, but it didn't decrease that gap across all of the measures that we looked at. So other policies are also needed, and that could be things like universal screening to make sure that all patients are receiving the screenings that they need especially before and after pregnancy.
Great, thank you. Danielle, do you want to introduce yourself?
Yeah, great, thanks. Thanks, Lisa. Ani Buju, my name is Danielle Gartner. I'm a citizen of the Sault Ste. Marie Tribe of Chippewa and also assistant professor at the Department of Epidemiology and Biostatistics at Michigan State University. I also usually introduce myself as a mom and a sister and an auntie and a relative too.
Great, I love that. So your research was on Native American populations and for pregnant women. So can you tell us a little bit about your research?
Yeah, thanks. So, I mean, first I'll talk about, I think, why this topic, why Native women, why the Affordable Care Act. And most people understand the Affordable Care Act is like this big law, right? And we're familiar with the Medicaid expansions, we're familiar with the dependent care coverage and all sorts of reforms that happened. But oftentimes I'm finding that people don't recognize that the Affordable Care Act also held many provisions that are very specific to people that are citizens of American Indian and Alaska Native tribes, of the federally recognized tribes, that is. And so we were trying to really understand what are those specific provisions and how might they have impacted pregnant people's experiences. So in our overall project, we used qualitative methods, we used quantitative methods to look at the impacts of the Affordable Care Act on healthcare access and use, particularly among American Indian, Alaska Native pregnant people. And we wanted to understand, were the impacts then equitable between American Indian, Alaska Native, and non-Native peoples? So in one project, and I think that's the one that's linked on the website for this, we again used the PRAMS data that Julia just talked about, and also important to note, that is the only nationwide survey or data source that exists on the experiences of pregnant people in the US, which of course is now not being collected, data being collected anymore, right, because of this administration. So we are left in the dark here in the future, and actually right now, on what's happening. But prior to now, we used some of the data from that from 2009 to 2015, and we looked at people who self-identified as being American Indian and Alaska Native alone or in combination with any other racial ethnic identity. And we wanted to understand their healthcare experiences in the 12 months prior to conception. So this is a group of people who eventually gave live birth, but this was their experiences and reporting of what happened before they got pregnant. And we looked at 5 pre-pregnancy outcomes that are kind of generally considered markers of sort of like general healthcare use. So it was, have you had your teeth cleaned in the 12 months before you were pregnant? Have you talked to a provider about your family's medical history? Have you interacted with a provider and gotten some healthcare screenings? done. And then we also looked at, in that month prior to conception, were you covered by Medicaid, and were you taking a prenatal vitamin? And so we took this time period from 2009 to 2015. We wanted to catch a little bit of the Medicaid expansions, and also prior to the time the Affordable Care Act was signed into effect. And we divided that time period roughly into like 7 different periods. And then at each time period, we calculated the prevalence of these outcomes, and then compared each time period to this reference period, which is the time right before the Affordable Care Act was signed into effect. And when we did this, we found that generally both those identifying as American Indian, Alaska Native, or white experienced increases in each of these 5 outcomes after the Affordable Care Act was signed into effect. Often the increases were like numerically larger among American Indian, Alaska Native people. However, I think it's really important to note that we all didn't start at the same place, right, at the beginning of the Affordable Care Act. And so what we noted then is that even though the increases might have been larger, the gains might have been larger among American Indian, Alaska Native people, they didn't even come close to offsetting the disparity, the inequity that existed already. Another thing that we wanted to do in this particular project, in this particular paper, was then to say, okay, the Affordable Care Act is this big law, and we know there's tons of heterogeneity among Native peoples and tribes. Geographically, culture, language, healthcare capacity, like who's employed by the tribe, and all of these things. And so we thought that probably matters in how tribes are able to take advantage of something like the Affordable Care Act, to understand all the pieces that matter for tribes. It's not like the government comes out and says, hey, tribes, here's how you use the Affordable Care Act, right? You got to have internal knowledge to understand how that works. And you have to have these like unicorn people, really, who know something about federal health law, who understanding about Indian health policy, who understand how about tribes work, how the Indian Health Service works, how these complicated health systems interact. Like, good luck finding those people, but some tribes have that and other tribes don't. So we were concerned that there might be some exacerbating of disparities within Native peoples and tribes, or the creation of inequities within tribes. And so that was part of the reason we started doing some work looking at geographic differences in these outcomes too. So we compared urban natives and rural natives on these outcomes too, and we saw that again, both urban and rural natives saw some increases in these outcomes after the Affordable Care Act was signed, which is great. This is what we want to see. And that rural folks, in fact, experienced the greatest increases in these outcomes.
Great.
Yeah.
Thank you. That's a lot. I love it.
Oh gosh.
Jamila, do you want to introduce yourself? And
Sure, absolutely. I'm Dr. Jamila Taylor, and I'm the president and CEO of the Institute for Women's Policy Research.
you have a wide body of research on morbidity and mortality of Black women. Do you want to talk a little bit about your work?
Well, first off, I want to say we need more of those unicorn people, right?
Oh my gosh.
Working in the space and ensuring that particularly vulnerable communities have what they need and deserve. So my research is a little bit different from what my colleagues have shared up here today. I have focused on how structural racism manifests itself in the healthcare system and what those implications have been for the Black maternal health crisis in this country. If we take a step back and look at the definition of structural racism afforded to the Aspen Institute, it's a system where public policies, institutional practices, and cultural representation work to reinforce or perpetuate racial inequity in this country. And so what does that look like in the context of the healthcare system? What I did was take a step back and look at the long history around reproductive oppression in the United States, looking at how enslaved women were used to advance the study of obstetrics and gynecology by using their bodies, clearly without their consent, for experimental surgeries in ways that would help advance reproductive healthcare, reproductive medicine for white women in this country. So if we think about that time period and the ignoring of Black women's bodies, Black women's pain, we see this perpetuation of this idea that, Black women have thicker skin. They don't experience pain in the same way that others do. And that has translated into how Black women experience the healthcare system today. There are countless stories out there that document how Black women, particularly in the maternal health context, have been ignored in the healthcare system. Even Serena Williams shared her own story of how she was ignored right after having her first daughter. And so for me, it was important to unpack the racism piece in all of this. And look, racism can be covert, but it can also be overt, right? So those cultural representations impacting perceptions of pain in the healthcare system, that's one way that we see structural racism manifest. And then I have also looked at healthcare policy, particularly when it comes to the Medicaid program. There's no secret that Medicaid has supported and covered so many families in this country. Right now, it covers about half of all births in this country. Women of color tend to be, overrepresented in the Medicaid program when compared to white women. White women make up a larger share of the population, but when we look at it proportionally, women of color are more likely to access their health care through programs like Medicaid. And so the Medicaid program for decades had, basically cut women off about 60 days after giving birth from health insurance coverage. These are women that entered into the program through the pregnancy pathway. And so as advocates in the community, thinking about ways to put a dent in our maternal health crisis, we took a step back and looked at that coverage gap, right? The fact that women were being dropped from that coverage and all of the challenges that it posed on women when they lose health care coverage. And so when I was at the Century Foundation, through a project funded by the Commonwealth Fund, I looked at what perinatal insurance churn, which is going in and out of health insurance coverage or even having coverage, not having coverage at all, having to switch between health plans, what that impact was, particularly for high-need women, again, who tend to be Black women. And what I found was that not only did it have an issue perpetuating poorer health outcomes, we saw that these women would forego services altogether when they lost health care coverage. It perpetuated poor mental health outcomes for these women. They didn't have access to family planning when they needed it. For women who were experiencing high needs, having a care coordinator, which is typically covered by health plans, was also now a challenge for these women. And in turn, because mom isn't feeling good or she doesn't have the access to the healthcare coverage she needs, it also impacts her family's care, right? And has long-term impacts on even the healthcare of her children. So that's another way that we see structural racism manifest when it comes to healthcare and health policy. And what the premise is behind this definition of structural racism is that, when we have policies and institutional practices that are put into place in ways that harm the most vulnerable among us, now I'm centering Black women in the conversation, then that's how we see institutional racism, also known as structural racism, manifest both in healthcare and in policy.
Thank you. Thank you. I'm going to go back to Julia. You've talked a little bit about how the identities within the Hispanic population of pregnant women really interact with the care that they receive. Can you talk a little bit more about some of your research on that?
Yeah. So I think the crux of it is that people are complex, right? And in the data, when we're looking at how we're going to identify or group different people, if you're not actually mimicking that complexity that exists in real life, you're not really getting what's actually happening to people. So everyone has multiple characteristics that impact their interaction with the healthcare system in different ways, and the consequences of that are amplified around the time of pregnancy and childbirth. So for example, say I'm a mom living in a rural community and I have lost access to my local maternity care services, which has been happening for decades in many rural communities across the US. That's going to impact my ability to talk to a clinician for preconception, prenatal, and postpartum care. If I'm a rural resident and I also have a lot of financial challenges and have less access to financial resources, that's also going to impact the way I am able to or not able to access care. If I also maybe am not a primary English speaker, and again, I have all these different factors that could layer on top of each other, That just, again, complicates the way that people access care and the way that they are engaged in the healthcare system. So again, we can't always see people's challenges. I mean, sitting up here, no one knows what my personal experiences or challenges are or anyone else's here. But again, trying to find ways in the data to try to match that complexity and tell a more complete story, I think is really important in research.
Yeah, absolutely. There's so much that we miss when we're just looking at data. And that's one of the reasons why the qualitative work is so important as well. Absolutely. Danielle, can you talk a little bit about the obligations that the federal government has in what's called federal trust responsibility? And if you could let the audience know what that means as well, that would be terrific. And also how it impacts maternal health.
Yeah, I'd love to. So, American Indian Alaska Natives that are citizens of federally recognized tribes, we have a unique political status, and this is distinct from any racialized, identity that's been placed on us. And this is what underlies our relationship with the U.S. federal government. The idea that federally recognized tribes held important relationships with the federal government is something that's even recognized in the U.S. Constitution. The federal trust responsibility, also kind of referred to often as like trust doctrine, is the legal obligation that the federal government has to ensure the welfare of Indian tribes and people. And this includes an obligation to provide services required to protect and enhance tribal lands, tribal resources, self-government, and also includes the economic, social, and other health programs that are necessary to raise our standard of living and our social well-being to that comparable to non-Indian society. So several federal level acts, as well as U.S. Supreme Court cases, uphold this trust responsibility, and several federal agencies even include language of this in their own policy. Ultimately, this federal trust responsibility provides the legal basis then for the provision of healthcare services to our people. So in exchange, right, for the land that has already been given or taken for tribes, which we have already paid for in full, the government provides means to support our health in perpetuity. And most think in the health space, think of the Indian Health Service or the IHS as the embodiment of the federal trust responsibility with regards to health, and the IHS does provide vital and good health care for Native people, including pregnant people, but it's chronically underfunded and not always geographically accessible. Moreover, we know that healthy births aren't just the product of, the quality pregnancy interactions that we have while we're pregnant. Determinants of, my child's birth they started much earlier than when I got pregnant, right? During my fetal growth when I was in my mom's eggs, where she was growing inside my grandmother, right? All of these experiences, including my childhood and early adulthood, impact the experience of my child and the birth that I had. So keeping that in mind, how it's not just pregnancy that matters for pregnancy and birth outcomes, as well as the federal trust responsibility, there's really an immense amount of responsibility then that the federal government has to ensure that we experience healthy social, economic, environmental conditions before, during, and after pregnancy. Clearly, though, I think we could all probably agree that this trust responsibility has been neglected and needs to have a bigger priority in our U.S. federal government.
All right. Jamila, from your research, you've done a lot of work on policies that the federal government and state governments can implement to improve maternal health. Can you talk a little bit about some of that work and some of those ideas?
Yeah, absolutely. Well, first off, I think it's important to acknowledge the fact that, particularly at the federal level, we don't have an environment that is friendly or supportive to the policies that, my organization is, trying to advance when it comes to the maternal health crisis. And that poses challenges, not only for us as an organization, but the broader reproductive justice, health equity movement. I think as we talk about policy solutions, we have to sort of ground the conversation in that way. There is a lot of work to be done. At the same time, we can't lose sight of our long-term vision and goals when it comes to policy. But we also have to recognize that now there are going to be some threats in front of us that we have to be creative as much as we can about addressing in the moment. So I do want to put that out there. But aside from that, there are some really promising policy solutions in front of us. The Black Maternal Health Momnibus is one. I'm sure, some of you here in the audience and watching online have heard about the Black Maternal Health Momnibus. It's legislation that has been led by Congresswoman Lauren Underwood. It is a package of 13 bills that address various dimensions of the Black maternal health crisis, everything from ensuring that moms have access to the wraparound services they need through the social determinants of health, addressing those, looking at the climate implications for the maternal health crisis, ensuring that we take a step back and look at how implicit bias and racism show up in our healthcare system through the Kara Johnson Act. It is really the most comprehensive package of bills addressing the maternal health crisis that we have yet to see. And then there are also some advancements that have been made around Medicaid, which I talked about earlier, that postpartum coverage gap that I talked about in the research that I have done, thanks to the Biden-Harris administration. We have seen more states take up, ensuring at least a year of coverage under the Medicaid program postpartum for new moms. And I'm really hoping that with Medicaid under threat right now, and cuts to the program that are on the table, perpetuated by the Trump administration as well as Congress in this moment, I am really hoping that they don't impact the gains that we have made in when it comes to getting more people on health insurance coverage, particularly when it comes to addressing the maternal health crisis. And then I think also thinking about the protection of data and the integrity of data, right? Again, another challenge that is before us and is under threat in this moment. So ensuring that maternal mortality review committees have the support that they need, both through funding, as well as having, the best group of experts and family advocates and others around those tables to unpack maternal deaths in different states across the country. So those are just some of the issues. But again, I think, a few years ago, when I was at the Century Foundation, we did, a tracker looking at the Momnibus as well as legislation that had been introduced on maternal health. And in the past, 5 or so years, we've seen so much legislation introduced to help address this issue. Including looking at the racial and economic implications for this crisis. And I'm just hoping that those efforts aren't stalled, due to the current administration and dynamics on the Hill right now.
Yeah. Julia, this issue of data has come up again. And we're going to lose the PRAMs. The Center for Medicaid Innovation is going to take the collection of racial and ethnic and gender identity off of all of their demonstrations, all of those data. And what it's sort of, I know you can just speak about the research that you've been doing, but what does that lack of data mean for what we know about what's going on in communities and what they need and how we can implement policy to improve those communities?
Yeah, so data really is essential for improving maternity care and for saving the lives of moms and babies, especially in the space that we're talking about in maternity care. Dr. Gardner already talked about PRAMs, and as I mentioned, that's what we use in this specific paper, but it really is an important source of information to be able to see what's happening, the experiences that people are having before, during, and after childbirth. And again, data like this really helps researchers and policymakers to try to even figure out where maternity care policies are working well, where they may not be working so well, to figure out where the gaps are and who is falling through those cracks. And so if you don't have that data to even figure out where things are going wrong, it's going to be impossible to improve maternity care and to, again, I think we hope our universal goal is to improve the lives of moms and babies, and without that research and without that data to support the research, we don't know where to fix things.
Yeah.
Can I make a follow-up point to that?
Yes, you may.
And just, I think another piece to think about, and you said it clearly, is that for me, the attacks on data are going to invisibilize, particularly communities of color when we think about the maternal health crisis. And so I think it's important for us to just think about that as we think through, what it looks like for us to try to do what we can to protect data, both in terms of integrity and also making sure that, our communities are counted. And, I think it's by design that, these efforts to invisibilize these communities really need to be put out front and center.
Yeah, and actually goes right to this, our first audience question, which is, any thoughts on the loss of funding for PRAMs and how researchers and policymakers can address this loss and gap? I also want to encourage all of you in the audience and also both here and online to submit your questions. We have a great panel here. You can ask away.
Yeah, I have some thoughts around that, I think.
Yeah.
And, in Michigan, we are a state that is in partnership with the CDC to collect PRAMS data. And, I think there's an opportunity here for, people to come together. We can still do this as a state. You can't keep me from talking to people, right? And understanding their experience and writing it down and that, right? So, we could do that. We could collectively do that. Volunteer our time. We could organize. Nonprofits could take up that space to coordinate. The CDC doesn't have to do that job. Other people can step in. So I think there's opportunity here, and this is where we show our true colors, our integrity here in these moments, right?
And that's an opportunity for philanthropy, for example,
Yes, for
to
sure.
step in.
Oh, interesting. I don't know. I don't know about that.
As well as state governments. I think there is going to be a lot of action at the state level, and I think working with state governments is a really important place as well.
Yeah.
And state and local health departments have those expertise on
Yeah.
running these surveys and collecting these data, and have expertise more than at the federal level for a lot of these things that are specific to their states and communities.
I also, in the space of opportunity, I hope I can say this, that I think there might be a time for us to rethink about what it is that we consider strong evidence to. And, maybe it isn't always this national survey data. It tells us a part of the story, but we can value more, or we can value to an equal degree, right, the words that come out of people's mouths and their conversations around that, right? We are, as consumers of research, are people that are allowed to, kind of rewrite what is the norm and the appropriate forms of evidence that we'll consider.
Well, storytelling is
Yeah.
data too, right?
Exactly. Exactly.
With a lot of the research that I have done around this issue, I've gone into states and talked to women directly about what it looks like for them when they don't have access to health insurance coverage and the challenges that they've experienced, not only themselves, but also their broader families, the economic implications of that, having to pay for healthcare services out of pocket. And that's even if you have the money in the first place, right? Most times, these women have to forego care altogether. And so I do think this presents an opportunity, with data under threat, for all of us to be thinking more creatively about how to center storytelling in the research that we do.
I completely agree. And I think we can paint pictures of different communities that have very different needs. You've talked about Native American people who live in cities versus in urban areas, and they are, face different challenges and may have very different needs. If you want to talk about that, that'd be great.
Yeah, I think about one piece about that is in terms of what I would consider a structural racism, a way that plays out in health policy is, it's Native people have always been in cities. We'll start there, right? And the reason that there are lots of Natives in cities anymore is not just by happenstance, there was federal policy that supported the relocation of Native people to urban centers. And then we see the proliferation then of these urban Indian organizations. And even now, I think, you know, depending on how you classify Native people and whatever else, but, you know, the majority of us live in urban spaces, in urbanized spaces and not in rural spots. And that matters because when we look at the way that allocation of money towards health services for Native people, particularly through the Indian Health Service, a dismal amount of money actually ends up going to these urban spaces. Like 1% of the entire IHS budget is going to serve urban people, urban natives, despite the fact that the majority of Native people live there, right? And so now I can't remember the question. Oh, the differences, urban, rural spaces. Yeah, I mean, so that's just one again, a chronically underfunded system is then disproportionately chronically underfunding urban spaces, which is the majority of where we live, right? I mean, I don't have an urban health org that is in my town to go visit. Yeah. And those are the spaces where we tend to be able to encounter healthcare providers who understand more about our families and our families' histories, who understand more about the cultural practices we might have and norms, who are less likely to generally just be like racist in our encounters.
Do you want to, I mean, this urban rural issue is not just a Native American issue.
100%.
And so each of you want to talk about that a little bit more? Because it's.
Yeah. So I can say when we're talking about access to maternity care service, I mentioned earlier about the declines in access to maternity services in rural communities that have been happening for a long time. Those declines are happening in some urban communities as well. It's not just a rural problem. But as I mentioned, right, people are complex and the challenges are layered, and what may work for one rural or urban community may not work for another. And so finding those policy solutions that are tailored to fit the needs of the people that they're meant to help is essential.
Yeah, I think just to follow up on that, you know, with what my colleagues have said, you know, we can't have a one-size-fits-all approach, you know, particularly when we think about something like maternity care deserts, which are everywhere, you know, and so I think we tend to talk more about, you know, sort of missed opportunities in rural spaces, and that means that we forget about, you know, those folks that are living in urban centers that may also have challenges accessing healthcare. And so I think it's important to think about everyone and recognize that, you know, some of the approaches need to be unique and tailored to those communities specifically.
And we're going to talk a little bit about that in DC at our next panel. So that.
Oh, great! Yes.
Great. You know, I know this is a question for all of you. I know, Jamila, you talked about the pieces of the Momnibus that look sort of at the more social determinants of health, all the wraparound services that influence, not services, things that we all have that affect our well-being. And one of the questions that came in was, how can sort of housing supports and public housing help support maternal health?
Yeah, great question. I do want to say that, you know, you're going to have Aza Nadari from Mama Toto Village speaking later in the program today. And shameless plug, I'm the chair of Mama Toto's board. But Mama Toto is a phenomenal organization based here in DC. And Mama Toto is doing a lot of work to support, you know, women and families experiencing, you know, a lack of you know, shelter. And so I think it's important that you're having an organization, a community-based organization, Black-led organization that is going to be able to have the stage today and talk more about what they're seeing in terms of these challenges. And look, I think there's a broader problem in this country around housing affordability. We can't deny that. You know, it's just interesting too when you sort of think about situating an issue around, you know, being houseless in, you know, one of the, you know, wealthiest power centers in the country, and that is Washington, D.C. And so it is definitely a problem. We know that depending on the situation of a mom and her family, she may be more likely to experience not having access to shelter, as a pregnant and parenting person. So I do think it's important that we center that into our conversations. This wasn't something, as someone who helped to draft the Momnibus years ago now, this wasn't something that we were able to sort of fit into, our approaches at the time when it came to legislation. And we had some conversations with HUD about this too. And there had been some programs there at HUD that were centering some of these issues. I wouldn't be surprised if, in this environment, they would be doing away with them. But I definitely think it's something that we should be centering in these conversations around the social determinants of health and like just general well-being for moms and families.
Yeah, I have, so we have another question from the audience, which is, have you seen success stories of implementing midwifery-led models of care to address maternal health inequities in the U.S., particularly for areas like maternal health deserts? And I'm going to put in another plug for and then let you guys answer, for the next panel too, because we are having someone from the DC government whose name I'm having a senior moment about right now, who's leading the Transforming Maternal Health demonstration in DC, which is a federal demonstration that is going to do a lot of different things, but also is really centered on the midwifery-based model of care. And so she can hopefully talk more about that, but I'd love to hear what you all think as well.
Well, I had midwives for all 3 of my births, so I love midwives.
Me too.
Yeah. I mean, so the access to midwives is dependent on state policy too, right? Like,
Absolutely.
Being able to do all the work that they're capable of doing is dependent on state policy and where they practice, whether that be urban or rural. Again, that depends on, I mean, a lot of rural hospitals and places where people give birth have workforce shortages, and that includes midwives. And if people are giving births in birth centers, there's also some states have regulations around how far they have to be from a hospital, but if you don't have a hospital in your rural community, then that birth center and access to a midwife is going to be challenging too. And midwives practice in birth centers and home births and hospitals and all different types of settings too. But yeah, I mean, we see in other countries where most births are attended by midwives, and that's appropriate for most normal pregnancies and births. So,
yeah. I think just a plug. When I think about the question around midwifery care and just thinking about the perinatal workforce, and one aspect of the Momnibus is to build the perinatal workforce, particularly when it comes to diversifying that workforce. And I think I would be remiss without giving a shout out to those midwifery care models that are led by Black women in this country, folks like Jenny Joseph, Aza Nadari, who you'll talk to later in the panel, and just a host of others. I know I don't have time to name all of them, but there are some really, I don't even want to call it innovative because they've been doing the work for so long. I think because now, the sort of Black maternal health crisis has more of a platform. You're hearing more about these models that have really been out there for decades. And I think we need to do more to call in these Black-led models of care, because the data shows that, they are actually saving the lives of moms and babies. And so, you all are in for a treat as you hear more about that later in the program.
And also on our third panel, Bruce is going to talk about some of the challenges he's had working in New York to open a birth center.
Yes,
so,
yeah.
This conversation around midwifery is so exciting, and I love that platform and that modality. And for birthing, I feel like some of the conversation I hear in Native spaces is complicated because midwifery practices of Native people have existed for millennia, right?
Yeah.
And now it's something that is regulated by the state. And so I think that's a spot where there's like some tension around. I've got people who have been practicing this their entire life based on like indigenous knowledge, and now am I going to be recognized by the state for that service or not? And then folks who then want to have indigenous midwives also feel a little bit, in some cases might feel terrified, about going, what does this mean for my birth if I'm having someone who's not actually regulated by the state to do this? And what does it mean if something goes wrong? What does it mean for my child and for interactions or interrelations with the state? So it's a spot of, needs to be more work and conversation around for sure.
Yeah, and then I'll also just to say briefly a follow-up to that too is that there's also a challenge in terms of like whether or not your insurance may cover, a midwife or even a doula. And so that's also a factor for, pregnant and birthing people to consider. Even if you want to have a midwife or, be assisted by a doula, your insurance may not cover it. And it's definitely a patchwork when we talk about the Medicaid program in terms of it's really about where you live and your zip code, which can be unfortunate if that is something that you're covered by the Medicaid program and you don't have that access.
So I have another question from the audience, which is, it's been mentioned a few times that honoring complexity is integral to the way forward. What tools, methods, approaches to analyze and action are important for better actualizing this complexity? I think you guys have spoken a little bit to that in terms of like talking to people, talking to communities, the storytelling that's really so important to getting people's voices out, because people's voices are so powerful. But I'm going to throw that out maybe as the last question to each of you.
Maybe I can start with the data side, because I do think that the talking to people is where a lot of that is. I mean, talking to people, you can explain that complexity better than you can with data points. But again, we also need data. I mean, you need both of them. They're both important. Again, I think as a field in research, we can try to advance our methods to find better ways to model that complexity. But again, even just looking at more than one angle, looking at more than one combination of different factors, which is not always done, and trying to do that more often and try to, again, not always just take the data for what it says, but understand what underlies that.
Yeah, my mind kind of goes to, thinking about the complexity of Native identity in and of itself. And I talk about the federal trust responsibility here, and, that unfortunately leaves out a chunk of Native people, right? Native people who are unenrolled, people who have been unenrolled, which happens. Tribes do kick people out. Or disenrolled, and then folks who are, member of state-recognized tribes or historically recognized tribes. That wouldn't then be covered under this sort of federal trust responsibility. The Affordable Care Act would not impact them in the same way because of the legal relationship that they may not have with the federal government. So that's a piece of complexity that I think about quite a bit with regards to Native people.
Yeah. I go back to, what we were talking about earlier when it comes to data, and I'm just so worried about the invisibilization of people of color and the devaluation of their experiences in this moment where we're seeing an assault on data. So from IWPR's perspective, we are taking a step back, looking at the fact that whereas, maternal mortality has gone down for every population but Black women, based on the most recent data that we've been able to get from the CDC, and thinking creatively, not about how we can advance or at least keep our eye on the ball when it comes to this long-term vision, when it comes to really realizing maternal health equity, but what we can be doing in this moment to share the stories of women who continue to face challenges when it comes to interacting with the healthcare system, and how the intersections of race and gender really create a perfect storm when it comes to the Black maternal health crisis in this country. So we'll keep moving forward and doing what we can. But this assault on data is something that is really, as a research organization, really keeping us up at night. Yeah.
I feel that for sure. So I want to thank each of you both for sharing what you know with all of us, but also for your deep interest, research, and passion for the communities that you are part of. And thank you so much for being here with us. I hope you'll stay for the rest of the day. And I'm going to turn it over to Wendy Ellis, who's going to moderate our next panel.
Thank you.
But I think we're going to have a little bit of a
Well, good afternoon, everyone. Did we get another cup of coffee and stretch a little bit? So, good afternoon. I'm Dr. Wendy Ellis. I'm the director for the Institute for Racial, Ethnic, and Socioeconomic Equity and the director for the Center for Community Resilience at George Washington University. I'm super excited about this panel because the first panel really got into the nitty-gritty with regard to what we know from the evidence with regard to research into maternal outcomes. But it's so important for us to be able to translate that research into action. And much of my work is really around how do we take what is the best evidence, working with community, to deliver solutions that work for, particularly for women, where they are and how they want it. And I'm so excited about this panel because that's exactly what this panel does every day, is translate that evidence into program and to action. So I want to start with, first off, giving the panelists an opportunity to introduce themselves and share a little bit about their perspective. What perspective are you bringing to today's conversation?
Starting down here? Sure. Hi, everyone. My name is Emily Johnston, and I'm a Principal Research Associate in the Health Policy Division here at the Urban Institute. And I am trained as a health services researcher, and I have expertise in reproductive health, maternal health, and the Medicaid program. And much of my work uses research, including quantitative data like birth certificate records and surveys, and qualitative data from speaking with people and conducting focus groups to understand the impacts of state and federal policies on the health and well-being of pregnant people, women, and their families. And some of the perspective that I'm bringing today, I'm wearing the researcher hat, and some of the work that I've done in this space is evaluating federal innovative programs in the Medicaid space, talking to communities in North Carolina to understand how they think community is shaping perinatal health, analyzing health insurance before and after pregnancy in the Medicaid program, and having conversations with Black and brown women about what they would like to see in maternal health care. And I'm happy to be a part of this conversation.
Thank you.
Hi, I'm Azana Dari. I am the co-founding executive director for Mama Teto Village, located here in the district. I am also a certified professional midwife, so I practice out of hospital. I'm also trained as a family therapist and a soon-to-be finished with my doctorate. And very soon, hopefully this week. But I come into this space as a mother first, and also bring to this conversation the lens of a clinician, but also the lens of someone who heavily works in community, is of the community, and what it looks like for community innovation to operate and exist in practice, and truly operationalizing transformation, both at the community level from the side of care delivery, but also from the side of workforce development.
And good afternoon. I am Melissa Bird. I serve as the Medicaid director for the DC Medicaid program. So from that perspective, I'm certainly here from the payer perspective and how do we support district residents throughout their healthcare needs. In the DC, we pay for anywhere from about 40 to 50% of all births. So we have a fairly impactful role. And just like Azza, for me, and when it comes to maternal health, I'm a mom as well. So I bring that perspective that's really meaningful to myself and into the work and trying to support folks. And I really think right now the role and where we can do the best is really listening to folks like Azza and Mama Toto Village of what they're hearing from within the community and how can we support that work, which is evolving. We're not there yet, but that's kind of the goal going forward. How can we better meet the needs of the folks that we're trying to serve?
Thank you. So Emily, let's start with you on helping the audience to understand a little bit more about the goals of your research and some of the key findings.
Absolutely. So the research that I'm focused on today is work with my colleagues Lisa Dubé, who you met earlier, Anuj Gangopadae, and Vincent Pancini. And we were investigating how structural racism, neighborhood characteristics, and maternal characteristics contribute to inequities in birth outcomes between non-Hispanic Black and non-Hispanic white women. And as Dr. Taylor gave us that great overview of structural racism earlier, that was really what we were trying to investigate in this research using quantitative data. And we sought to answer two specific questions in our work. The first was, how does community-level structural racism contribute to the disparities that we are observing? And for this piece, we compared rates of preterm birth and low birth weight among Black and white mothers in counties where we observed more evidence of structural racism and those where we observed less evidence of structural racism. And not surprisingly, to those of you in this room, we found that adverse birth outcomes were correlated with levels of structural racism. For all infants, those residing in areas with the lowest levels of observed structural racism had lower rates of preterm birth and low birth weight. And those residing in areas with higher levels of observed structural racism had higher rates of adverse birth outcomes. But at every level that we were investigating, we still saw these persistent Black-white disparities where the adverse outcomes were greater for infants born to Black mothers. And importantly, we also saw that in the areas that had the lowest levels of observed structural racism, infants born to Black mothers in those areas were still more likely to experience the adverse birth outcomes than those born to white mothers in the areas that had the greatest disadvantage. And so the key takeaway here is that residing in an area with less observed structural racism was not enough to protect Black families against these disparities that we're observing in the evidence. The second piece was to switch from thinking about levels and think about the impacts of different characteristics that people experience in their communities or in their personal lives and how these vary by race. So we used a decomposition analysis and considered how differences in levels of characteristics affected outcomes and how differences in the effects of characteristics. And that's a little bit different from how we might typically talk about this. So an example is that living in a wealthier area or having a more educated mother, these are characteristics that in the data at the population level are associated with better birth outcomes. But they might be more protective to infants born to white mothers than to infants born to Black mothers. And we considered factors at the area and individual level and found that about half of the racial disparities that we were seeing in the data were due to differences in the characteristics that we could observe. But the other half were due to differences in the protective level of characteristics that different groups received. So residing in a neighborhood that was wealthier or having a more educated mother was more protective for those white infants than for Black infants. And said another way, thinking about the policies that we typically see in this space that focus on levels and trying to transfer resources to communities in need, our research suggests that that might only be able to reduce about half of the disparity, that the other half is this really ingrained structural racism that is impacting birth outcomes through the way that people are treated, either in interpersonal interactions or in the system in which they reside.
I want to pause here for a moment because given the current political context, as we used to tell our children, I'm a mom too, use all your words. And I think it's really important for us to unpack, particularly with your work, what do we mean by structural racism, how we are actually measuring that, because this is not something that is just a overarching term. There is a definition, but from a research perspective, you're talking about differences that you're measuring in the experience of structural racism. I think for this audience and for those who are watching, it's really important for us to really think about how are we actually measuring the experience of structural racism to connect it to the outcome of interest for you.
And that is such an important question and one of the major challenges in this area, because how can you measure something that is so pervasive, that affects so many different levels of society and so many different components? And what we used in this work is a measure of racialized economic disadvantage. The technical phrase for folks who might be more familiar with the research is the racialized ICE measure, or incidence of concentration at the extremes. And we were comparing the share of the population that is higher income and lower income, as well as the share of the population that is Black versus white at the county level. So in this analysis, counties that were identified as more advantaged were counties that had a larger share of residents who were high income and white. counties that were identified as disadvantaged were those that had a higher share of residents who were low income and Black. And that is designed to capture both the racist and classist impacts of different policies and interactions that people experience.
I appreciate that definition because I think it's really important. You know, your second part where you were explaining about some of the factors with, you know, concentration of community wealth or poverty or educational attainment could be dismissed as, oh, that's not structural racism, that's social determinants of health. But what you're really explaining to people is that structural racism is an umbrella under which all of us exist, regardless of race, but it's the degree to which you feel the impacts that are making the difference. So thank you so much, Emily, for that moment of doing a little bit of nerdy analysis here. But I think it's important, like I said, to use all of our words to make sure that people truly understand the experience of structural racism. So Aza, the star, because I mean, everyone was talking about you in panel one, so here she is, finally. Can you talk about the model and approach to the Mothers Rising Home Visiting Program?
Yes, so we designed the Mothers Rising program at Mama Toto to be more than just a service. It is truly a lifeline for so many Black women and birthing people who have been historically and systematically marginalized in traditional healthcare. This program also really centers the resilient potential of Black mamas, considering their autonomy and their dignity as a component of how we give care. And then we layer that to, we like to say, we wrap around this cultural congruence and cultural resonance with that program being staffed by people who come from the same communities in which we serve. And that is very intentional at our organization. Our model is also kind of framed in our theory of change, which we take a 3 generations approach. And how we have defined that is that it is important to consider the well-being of the entire family, not just the mother-baby dyad, because in Black communities, right, our grandmothers, our mothers, our aunties are all a component of how we evolve in our health education and our health literacy, in the stories that we pass down and share. And that informs how we parent, the decisions that we make, how we enter into healthcare. So a component of our work is not only just educating the mother, but also educating the grandmothers and the aunties and anybody else who is in that family to really move the entire family towards better well-being and increased health literacy. The other part of our theory of change is geographic proximity or social proximity. Again, making sure that the people who work within our organization and who are delivering care are from the community, who understand the people that they're serving, that they speak the language, that you see the people that you serve at the grocery store. It builds trust, it builds connection. The other component is training. So we have a workforce development training, and that training not only creates stepping stones, which I'll talk about that a little later, but it also creates economic stability for the women who are part of Mama Toto Village. And then lastly, it's that piece of cultural congruence, right? It's not enough to have people who look like you, but it's also important for people to anchor your dignity and your humanity in the ways in which you are provided care. Our clients at Mama Toto are about 91% Black. All of them are 100% Medicaid eligible. We use eligibility as a criteria versus saying everyone is on Medicaid because we do have families who work, right, and who have an employer who is covering their health insurance, but they still fit into the same criteria and the same profile as the rest of the families who we care for. 76% of our families have partner involvement. That means there's a dad showing up, there's a partner showing up, right, to the table. 59% of our families are below poverty when they come in. Most of our families have $0 to $14,000 of income. That is the average at Mama Toto Village. 43% have inadequate housing when they come into the door. And then all of our clients are moderate to severe risk when it comes to health and social factors. So in our approach, we don't just consider the clinical, we consider the social also as a risk factor, as we know that socially related health needs contribute more to maternal health outcomes than just those clinical components, even though the clinical is what is heavily invested in. When we pair families with a full team. And so that team is comprised of a perinatal community health worker, a care coordinator, a nutritionist, an emotional wellness specialist. So this is the behavioral health piece. They get lactation. So we have all these people who are wrapping around, who are meeting the needs. We intentionally designed the teams that way to prevent burnout, which is very common in direct service work and community health work. And so we try to create a protective factor so that there's shared responsibility and there's shared expertise across the team to really wrap around that family. We also provide respite care, daytime and overnight support in the home for our families, in addition to labor support that is managed by our community birth workers, our version of a community doula. And all of this is covered by Medicaid, which is amazing. So we have contracts with all 4 managed care, Medicaid managed care organizations in the district. And it really does, not only does it create economic security for Mama Toto as an organization and viability for this program, but it also allows us to pay equitable wages to the women who are delivering the services. I am proud that Mama Toto has one of the highest wages in the country for home visitors at a starting salary. So we start our folks at $57,000 to $60,000, and these are women who often have high school diplomas when they come in. Our women do end up pursuing, not all of them, but some of them, higher education, but that is a starting point, and it is really important for us as an organization that we are not perpetuating poverty in our staffing population and in our frontline staff as they are doing this work. The impact of our program really speaks for itself, and so in 2024, we served 297 people in our home visiting program. We have more that were served by the organization as a whole. 88% of those families had full-term deliveries. The average gestational age was 38.2. 86% of our folks initiated breastfeeding at delivery. And then for the last 10 years, we've been able to maintain a 0% maternal mortality rate. And we've served over 3,000 women in the DC region in this particular program. And so, you know, for me, it's what we are doing at Mama Toto is not anything new, but it is about returning power to community. It's about returning power to Black women, that they are leading in their care and that we are here. I always say that we're just a mirror to reflect back their own power. We're not empowered. We're not giving you anything that you don't already have. And I will say that's the Mama Toto difference.
You know, I would be remiss to not put a pin on what you talked about when you first opened up. You talked about the resilience of the Black women that you work with, but you also describe these layers of supports that it's not an inherent, like, we are born strong or anything of that nature, but it's the community, the strength of the community that really does provide that resilience as you described. And it sort of speaks to what Emily was saying earlier about the factors that play into whether or not an individual is going to bounce back, or as we say in our work in community resilience, bounce forward. And what you're doing in your programs are actually providing those factors, whether that's in supports that are supports for the families, creating a community, or in the buffers, such as the workforce development. And I think that's so important when we think about how are we going to address holistically not just the mother's needs or the birthing person's needs, but also that child and that community, that village that is going to take care of these individuals. So the power piece is also a resilience factor because it speaks to having motivation and having agency. And you know what else motivation and agency are? Those are 2 key factors of hope. So not only are you building health, but you're building hope for a community, and that's so important when we talk about maternal outcomes. So where's the government's role in fostering hope? You know, I mean, I think, Melissa, at the end of the day, these are things that are measurable, though. They're not something that are ephemeral. There are validated hope scales. There are definitely scales for us to measure resilience and understand the efficacy of the supports and the buffers that we can put in place. And so can you tell us a little bit about this model that has been put in place here for Washington, D.C., by the Centers for Medicaid and Medicaid Services, Medicare and Medicaid Services, transforming maternal health model?
Sure. A couple things, or I'll start out with first, that I think is really important to know about DC. I'm wholly biased. I think it's a phenomenal city. I think we have tremendous supports, and there's a really fantastic, going back to community of people who are dedicated to making better healthcare for the district. One of the things here we cover through the Medicaid program, pregnancy up to 324% of the federal poverty level. I think that's the second highest across the nation. And we, of course, extended the postpartum up to a year, although most women who are already on Medicaid are likely to maintain their Medicaid after pregnancy in the district. And I think that's really important because when I first started in health policy and Medicaid, it was just all about coverage. Let's get folks coverage. Coverage gets you to access, then the access will get you to care, to better outcomes. So we have a lot of really great coverage in district. It's near universal, but our outcomes, particularly when you look at maternal health in the Medicaid population, is not quite where we want to see it. So it begs that question, why not? If we have coverage, you have access to services. Most folks know they have some kind of access. So the next question is why aren't you getting the care that you need or that you want? And I do think it's important to just, I think sometimes the notion is that folks aren't accessing care, and I think we've definitely seen moms and pregnant persons in the district accessing care, but they're not getting the care that they need that speaks to what will help them have a better outcome. So those questions about how you really engage with the healthcare system, I think, while from my vantage point is a much more difficult question and thing to resolve, is I'm at the place now, I think that is our biggest obstacle on how we move forward. So coming back to the Transforming Maternal Health Initiative, which was just awarded to 15 states and the district at the beginning of January, what I am hopeful for, so you've heard about the Mama Totem model, which is one of the amazing models that sees the outcomes that we want to see, particularly for folks who are on the Medicaid program. And there are other tremendous efforts across the district too, through our federally qualified health centers that have programs that are similarly intended to provide that holistic care and really like, how do I help the individual? How do I help the family? And while we pay for births clearly and pay for a lot of health care, we don't always pay for everything that is needed to really make that holistic approach viable. So we have organizations that do great work, have great outcomes, but the ability to have sustainable and assured funding, I think, is really a question. And folks oftentimes have philanthropic funds, which is fantastic, but they're usually time limited. And so if you really want to be able to ramp up some of the great work that we see in the district, I think having that sustainable funding is necessary. And in my mind, that's where we call it TEMA. That's where TEMA comes into play. I think for the district, it has the ability to be kind of the synergy that's needed to bring together all the disparate groups that are doing amazing work, and how can we talk about how Medicaid can pay you in a way that supports the holistic work. So it may not be for this code and that code and that code, but preferably more of a bundle. So when Aza sees someone and they need X, Y, and Z, the payment she's getting from Medicaid can support that care. But if a clinic across the town is seeing someone else who needs different, maybe needs more home visiting or needs some wellness or therapy services, those services can be tailored to that person and they're getting that support. So right now we're in the very beginning planning stages. We got award notice or February and January. The first 3 years is about planning, and a key component of that planning, besides really making sure we shore up some of the benefits that are already available through Medicaid, is really listening to the folks that are district residents, particularly those on Medicaid, and what is and is not working for you.
I think that last part is so important because, you have the wisdom or the expertise of researchers, but then you have the wisdom and the real expertise of those who are in community. So how do you plan on going through that process?
I feel like, and others obviously may agree or disagree, but we've had a couple planning groups or task force on maternal health and perinatal mental health that we, baseline involve lived experience. And it was, all the, kind of folks that you would have in maternal health, whether it's the woman receiving the care, midwives, doulas, payers, OBs, et cetera, and having some really, I think, honest and forthright conversations and hearing all those different perspectives. And that's the same kind of model that we'll engage going forward. I really do hope to dig more on the lived experience because I've been in this role now, I think about 6 years, and while we have, again, a tremendous array of benefits and supports, I think we need to really see how we can better tailor them to meet the needs of the folks we serve.
Yeah, and so Aza, maybe you can share some of your wisdom in implementing, something from the ground up with regard to the evolution of Mama Toto Village. It has really been adding services as you've gone along, even into the workforce development. So how did that come about that, you shape your programs in a way that not only are you satisfying the needs of moms in 1 year, but you're actually growing and learning from them at the same time?
Yeah, so the workforce piece was actually the catalyst for Mama Toto. The service came second because we needed work for the people who we trained. So it really came from Cassetta Pringle, who's the other co-founder of Mama Toto and who leads our lactation program. We connected in through another organization, Birthing Project USA. We started a birthing project here in DC with teen moms, and at a point we kind of realized that we were way in over our heads, and we decided to partner as doulas together, and just realized we weren't adequately trained to serve not only the teen moms who would come through this project, but we weren't adequately prepared to actually serve the community that we wanted to serve, which is the community we were both a part of. Both of us were younger moms. We had children. We had young children, and I at the time was in midwifery school, and we came together and developed this training, and it came both from, for me, an intersection of my midwifery education as well as my training as a therapist, and like bridging those pieces, and then layering that, or really using that community health worker training as a foundation and as a blueprint. And so that really catalyzed our first training. And we put it out there to the world, and people came, and we were surprised, and it just grew from there. So we're about 13 cohorts into our perinatal community health worker training, which is a term like we coined back in 2014, which is like, it is creating a new profession and a new career track. And so since that time, so in present day, fast forward 12 years now, that training is now about 226 hours long for a perinatal community health worker. We also have our community birth worker training, which is for those who want to be a community doula, so that's about 60 hours. And then we have an advanced lactation specialist, so those are for individuals who are interested in pursuing an IBCLC, that's a clinical lactation or board certified lactation track. And we facilitate these trainings at Mama Toto Village. We support the folks who come through this training all the way through those journeys. We give scholarships almost 100% of the time to make sure that the training is accessible. So we do fundraise to be able to ensure that. We provide books to the train. They don't have to come with additional costs. We give them everything they need to get started once they're done with our training. And then we also hire some of those people, not everybody, but we do hire some of those people as full-time employees with Mama Toto, or sometimes they'll go and work at other community-based organizations. So some people are at Mary Center, some people are at Community of Hope, and some of them are already in careers, so they are coming to Mama Toto strictly for professional development. But that has been our model for the last 12 years. And we've trained about 250 people in this model. And the individuals who have come through Mama Toto, we have people who are midwives now and practicing in the community. We have a few folks who are OBGYNs and who are practicing. One of them works at Howard. We have folks who are social workers and therapists. And so people have gone so many different pathways just by having this stepping stone into the maternal health or perinatal health profession. And for us, again, it's like critical that the workforce come from the community. And to me, the community is an untapped resource. And I think the difference with Mama Toto's trainings are that we are not looking for you to walk in the door with academic credentials. We are providing you with a trade, with transferable skills, and people can leverage those skills in whichever way they see fit. But the key is that they have the skills to take forward to building security, financial security, economic security, and building a career for themselves. So that's been the work that we've been doing. And next, we're building a midwifery school, and so that'll be like the next to kind of add to the add to the that'll be our last. That's our last track. We're not doing any more after that. It's the last thing. But we are the East Coast doesn't have for certified professional midwives. There is no midwifery training for them on the East Coast, and there's only one other Black woman who has a midwifery school, Jenny Joseph, in Florida. So there is a need, and the midwifery field is very small when it comes to Black midwives. And so that is something, there's been a 20% increase in Black women having birth out of the hospital, but there's not enough midwives to meet that demand. And so we want to be a part of the solution and make sure that, again, folks are well trained and have viable pathways, again, to security. Economic security is critical.
Yeah, absolutely. So you've just in that really answered the question that I'm going to pose to Melissa next. Actually, I think it's
so what she said,
I think it's appropriate for both Melissa and Emily. You have been able to, Aza, identify systemic barriers and then come up with a solution. Whether that's, you do it yourself or you reach out to other partners to do that. But Melissa and Emily, Melissa from a programmatic standpoint, from a policy perspective, and also you, Emily, from a research perspective, can you provide any examples or stories that capture the experience of systemic barriers or issues preventing mothers from reaching out for care or support?
Sure. There are two things that come into mind for me. And it's honestly, it's kind of what I carry forward with me in my work. First, and this was several years ago, we were at a council here in DC. Our legislative is a city council, and it was on some maternity-related legislation. And we feel very good about the coverage we provide. We do doula services, we have midwifery, we have lactation, et cetera, et cetera. And they're, testifying, the public, it was a mom who is a participant in the Medicaid program and, sharing her frustration that she was, directed or her doctor said, you need bed rest. And she didn't fully abide by that because she's a single mom, and how am I supposed to adhere to bed rest when I need to take care of my child, I need to take care of my house and so forth. And so for me in that moment, it was like, okay, we have these great things, but we're missing the mark here and actually helping this individual out. So it's trying to think, not all of the issues that were raised in that scenario for me, can be solvable through the Medicaid program, but I think the awareness of that particular experience is really important. The second one that is always front of mind for me through our perinatal mental health task force was, having a mom talk about I'm not going to call or reach out, or I have concerns about reaching out for therapy or mental health because I think I might get a call from Child Protective Services. And, in my world, quite frankly, that's not something that would have gone through my mind. I don't expect that would probably happen, quite frankly. I've done a lot of therapy myself, and I haven't gotten calls from, CPS. But that's a real concern. So instead of, thinking about, blaming someone for not getting the care they need, there's a real decision that, in that case, that mom was making to protect her family and herself at the risk of her own health. And so I think it's those kind of nuances and experiences that are so important to understand. There's a reason, again, going back to my earlier comments, if you have the access to care, then what is prohibiting you from accessing it? And I think it's those pieces we have to really drill down on. I also think it's not the easiest work, but I think it's really necessary work. So for me, those are the things that kind of, I keep rooted for myself when we're trying to make policy decisions or so forth. And one example in that is when we were setting up our doula service, our team internally was like, do we do 8 visits And then if you're high risk, you can have 12. So to your comment about what's clinically necessary, I can say high risk as a clinical designation, but we're talking about a population of low income people. That right there is a high risk designation. And we're talking about majority brown, black and brown people. That's another high risk designation when it comes to maternal health here. So in that sense, it's like, guys, we need to think about what is high risk. How are we defining that? And what we did, we just said the policy is you get up to 12 visits, and you as the individual, you choose how you get those visits. You know, do you get them all during your pregnancy? Do you want to save more visits for postpartum because that's what serves you better? And so I think it's, you know, taking those messages and what we hear from the lived experience and then bringing it forward and realizing, like, I don't know what's best for that mom and what she needs, but I can, you know, we can help set policy that allows the flexibility so that each individual can, you know, kind of get what they need from that.
I want to stick on this piece about the immigrant population here, because currently, you know, the context and the targeting of immigrants in our country is really frightening for many people that you serve, Aza, that we all serve in one way or another. And there's two parts to this, because DC Medicaid reimbursements are quite generous compared to the rest of the country, 70% versus 50%, right? And that is under threat of being reduced for federal tax cuts. While at the same time, we have all of the immigration rhetoric that, you know, given our large immigrant population, they are feeling particularly vulnerable here. So how are we making patients or those that we serve in this community feel most safe while also safeguarding our programs?
Well, I'll start on the safeguarding the programs. The reference is a proposal to reduce DC's, we call it FMAP, but it's the amount that the federal government contributes to our Medicaid program. It's 70% in the district, 30% 70% from the federal government and 30% from the district. The proposal is to bring that down to 50%. That would just have a tremendous impact. You will hear it referenced as a special FMAP. It is different than other states, but it's a recognition from Congress back in 1997 that the district does have state responsibilities, but doesn't have all the authorities as states. It's really specific when it comes to like taxing and where revenues we can bring in as a city. So for example, Congress precludes the district from taxing people who work here but live elsewhere. States can do that taxing function. And then there are other things that are unique to the district from the amount of federal lands that we have and height restrictions which impact property taxes and so forth. So from that vantage point, I think is making sure that all of our partners across the city understand the proposal that's at hand and folks can follow up as they see fit. The question on how do you ensure patients feel safe and still comfortable accessing care. You know, we're not at that provider level, right? So that's a more difficult question for me to answer. It has been a question that's been top of mind over the meeting with providers before coming in here. And it really is, I think, trying to stay in the moment in the sense that there is no change yet. There's a lot of information that could impact, but right now, you know, we are focused on our day-to-day operations and making sure we can serve the folks that we can. And I think for providers as well, and Naza could speak better to this from her perspective, but it is reassuring that we are here, you have access to your benefits, and please access care if that's what you need.
Yeah, it's an interesting question. I think that the concept of safety for a Black person living in America is always precarious. In that healthcare is does not exist outside of that bounds. I think that trying to almost persuade somebody that they are safe when everything that exists around them is often unsafe. It is challenging. You know, I think that at the individual level, as a clinician, the best thing that I can do is respect your humanity and dignity, and create a what we call a brave space, and a safe space within the confines of our organization, ensuring that everybody who walks through that door is treated in a certain way, is respected in a certain way, is held in care in a certain way. Whether that from our staff all the way down to our volunteers and our donors and all the people who are part of our organization. Outside of that, it's difficult to control that. The families who we serve often live in unsafe communities. And so when we're talking about safety in healthcare, it really is an extension. So when you're talking about built mistrust, there's mistrust in the systems who have failed to protect you in your home, who failed to protect you in the community that you can't walk around in. When we talk about, oh, you need to go out and exercise more, well, where am I going to do that when I can't walk down the street without fear of being attacked or catcalled or shot? And I think that it's a very nuanced thing when we think about this concept and idea of safety, and I don't really have an answer other than what is in the control of the individual provider level that we can control. I can control how we care for other people and how you are made to feel when I am with you during your birth and with you in that postpartum and pregnancy journey. We can control that. Everything else, honestly, we're providing Band-Aids to deeply entrenched racism and deeply entrenched redlining that have cultivated and nurtured spaces in which some communities, even in the district, it is the city of the haves and the have-nots. East of the river has so much wealth of people in history, but it has so much less in terms of the resources that the people need to thrive. If you have east of the river that has 3 grocery stores, but where my kids go to school in Ward 3, there's 10 grocery stores, right? I mean, just simple, we're talking about safety and access, even access to care. Access is it's an illusion. I can have something, but is it quality? Is it what I actually need? Did you ask me if what you were providing me was the thing that was gonna actually meet my need? And so I'm always trepid when we have this conversation around access, because I'm well, who provided it? And did you ask the people, was it what they wanted in the way that they wanted? And is it available for them in a way that they can actually utilize it for themselves? And so it's not just about access, it's also about quality. And safety also is a component of that as well. I have to be able to access safety in my body. Do I have autonomy over my decisions? I have to be able to access safety when I'm raising children in dignified housing in the communities in which I live in, which is reproductive justice. I have to have safety when I'm moving through space, and whatever my immigration status is. I think all of these connect together. And for me, it falls under, what the tenets of reproductive justice are really ultimately about. Safety is not just a luxury. It's not something we should be thinking about in hindsight or try to make policies around safety. It is a human right to be able to move through the world and move inside your body at all times with full autonomy.
You just aptly described the experience of structural racism on multiple levels, across multiple systems, but also you laid out a framework for change, real change. And so, Emily and Melissa, I'm going to ask you from your perspectives. Emily, what can the healthcare system do to change, to improve the outcomes for birthing people in this country, particularly Black women, particularly in that context that Aza just described?
I think succinctly in what we have heard Aza describe so far is how can we support more places of care in the healthcare system that look like Mama Toto Village, that are thinking through the questions that you are grappling with in the care that you are providing. The evidence shows that the midwifery model of care is likely to help reduce these racial disparities, and it's largely, when we think about our research and our findings, that there are these differential effects. It gets down to the quality of care that people are receiving. And so do they have time with a provider to actually talk about their needs that might be broader than clinical, that might be social? Do they have resources that they can be connected to, either from that clinical experience or in the community where they reside? Do they have a provider who has experiences like them, who looks like them, who has empathy for their life history? Is that something that we can build through workforce development of a more diverse workforce that includes midwives, that includes doulas, that pays them for the care that they are providing, and training for other folks? In one of the interviews that we did with Black and Brown birthing mothers, she said, I want someone who treats me like a human. That should be like the bare minimum of the type of care that we are providing, of the goals that we are setting for ourselves. So there are opportunities for improving the quality so that when you say someone has access to care, is it really access to the care that they need? Or is the reason that we're seeing differences in the effects of these factors because we're saying, well, you both have access to care, but for one person it is meeting their needs, but for another person it is not meeting their needs. So workforce development, changing to a more holistic model of care, and then addressing social determinants of health, either through clinical connections or in the community where people reside.
So Emily and Aza have described very thoroughly the challenge ahead, right? But can we just get real here for a moment? How do the current, the DEI EOs coming from the president's office influence the CMS funding and the work of TEMA?
Great question. I don't have an answer to it. What I can tell you is we haven't received any guidance that change what our expectations are for TEMA right now. Regardless of that, I think, or not that I think, our approach with the TEMA model and the work that we do is still going to include the folks that are district residents. We're going to make sure we have representation across the board. We're going to hopefully try to create, policy that is fair, and that folks who are coming around the table and the way we're executing policies make people feel valued. And so that doesn't, I don't think that changes our approach on things.
So I know that we're running a little over time. Do we have time to take any questions from two? They're not short ones. So I'll dealer's choice here. So how about this? We've talked about disparities, but how can researchers and practitioners elevate community efforts to provide a strengths-based approach to current maternity care solutions?
That's a great question.
Just clone
Just do
Aza.
So it's something that we try to incorporate when we're doing evaluation work. We're looking at the metrics, we're doing the quantitative analysis, but we also try to do case studies where we go and we speak with organizations. Sometimes we'll have the opportunity to go and visit places where care is being provided. And in those cases, we can produce a case study and say, here, in this evaluation, we got to observe this type of care provision model. Here's what was working. We conduct focus groups in that sense where we talk with patients and we ask them, what do you like about the care that you're receiving here? What would you like to be different? Another area that we're thinking about is switching to some bright spots analysis in addition to disparities work. So not only highlighting where there are problems and documenting them, but highlighting where perhaps outcomes are better than what we might expect and investigating to find out why that might be. And so that can help illuminate what solutions might work in other communities as well if we're able to transfer or scale programs.
Yeah, there's some great work that's coming out of Tufts University with Dr. Bob Segi and his HOPE framework. So healthy outcomes from positive experiences. And it comes from that framework of adverse childhood experiences, but it looks at it from the dyad, the parent and child dyad. So where there is the presence of these positive supports and buffers, much like what you described, Aza, what are the outcomes that are associated with that? So it gets us away from that conundrum of trying to measure what doesn't happen to actually how does this support contribute to a positive outcome. Did you want to add anything, Melissa or Aza?
No, I was just going to say, I agree. I think also in research and in policy, like language is also critical to shift in terms of being deficit-based language to more asset-based and strength-based language when we're talking about folks in the community, and when we are naming problems, naming them aptly and correctly, and kind of always say like using language as a tool to keep the focus where it needs to be, as opposed to using language that can sometimes even seem to blame the people who are most impacted by systemic racism for their outcomes. I think the other thing is using disparities as a way to contextualize and then anchor that in, the solutions as well. So I think you can have both together, but to me, painting the picture for the context is important to understanding why there was a need for a solution.
Do we have time for one more? Okay, so it's time to wrap it up, but I want to give you, the three of you, final word. If you have final word.
Thank you.
Well, I think that you all actually do provide, it's sometimes a very sobering topic to talk about maternal health equity, but you provide some bright spots today, some opportunities for hope, and definitely some opportunities for growth here in the district. And I think that's really important because our next panel is a pair of gentlemen who are some unreluctant heroes, but are stepping up to the challenge of continuing this charge of advancing maternal health equity, and we can't wait to hear from them. And thank you so much for all that you're doing for the field and for our moms and our children.
Good afternoon. I am Nona Mitchell Richardson. I lead the communications team at the Policies for Action, and I am very much looking forward to facilitating this next conversation entitled Turning Grief into Action, Black Fathers Seeking Solutions. Before we jump into that conversation and I bring out the panelists, we want to show you the trailer of the documentary Aftershock, in which both of our panelists are featured. So we're going to take 2 minutes to watch that, and then I'm going to bring them on.
My daughter's story is loud, colorful, and artful. She was awake, aware, and active. And yet she still died.
After she gave birth, Shamani was complaining that she had really sharp chest pains.
The ambulance came. I'm telling them the symptoms. Is she on drugs? Next set of people come in. Is she on drugs?
They kept asking her mother, is she on any drugs?
I'm like, do y'all talk?
We waited a solid 12 hours.
She's gone.
Black women are 4 times more likely to die than their white counterparts with the same symptoms. Why is that?
This is a growing epidemic in our community.
Hundreds and thousands of men are going through this same situation.
Oh, you couldn't tell me that I wouldn't be there.
I've never lived in this house without her.
You just gotta keep pushing forward. I can't let Amber be another statistic.
I had a plan, I had it mapped out.
If these numbers were flipped around and white women were dying at the rate that black women are dying, it would be a national crisis.
We fight against maternal morbidity event by event in order to create change.
We can turn our pain into power and make something of this.
Shamani Gibson, we hear you, we see you.
I planned on spending a lifetime with Amber. I wanted to give her my life. This way, I'm still going to.
Sometimes change.
The revolution will be tweeted, Instagram, Facebook.
This fight is not over.
When black mothers die, there's a ripple effect. We call it aftershock.
Sometimes change.
I strongly encourage anyone who has not already seen the documentary, please go watch it on Hulu. Get the 30-day trial, get it for free, and please watch the documentary. And so now I have the privilege of bringing forth our panelists, Omari Maynard and Bruce McIntyre III, hoping they're coming out. You all can join me. Thank you guys for being here. Omari Maynard is the co-founder of the ARIA Foundation and the partner of Shamani Gibson. Bruce McIntyre III is the founder of Save a Rose Foundation and the partner of Amber Rose Isaac. Bruce and Omari, I hope that I speak for everyone here when I say I'm so very sorry for your loss. And we really appreciate you taking the time to share your lived experience and your knowledge about this issue on many, many levels. You are the faces, the real humans inside of those statistics, inside of that data, and we really appreciate you making this your life's work to really end this crisis. Thank you so much for being here. So it's been 5 years since you lost your partners, Amber and Shamani. And incredibly, you both began telling your stories like almost immediately, which is astonishing and commendable. There's a lot that we're going to talk about today, but I would love it if you would start with telling us what you'd like to know, us to know about Shamani and Amber.
Definitely. Good afternoon, everybody. It's great to see you all. Super appreciative to be here. Thankful that we're continuing this conversation and that the work is going to amplify the way it is because it's extremely important. Shamani Gibson, she's the mother of Anari and Kari. She's the daughter of Shawnee and Mark. She's an amazing woman. When we met, we both were working with children at the Police Athletic League and, quickly created a relationship. Shamani was one of the only, very few women that just had an entrepreneurial spirit. Like, she worked at Police Athletic League, but she only had a part-time job. Everything that she did full-time was for herself through her entrepreneurship. So she was a dancer, she was an artist, she was a hairstylist, choreographer. She did a ton of things. And, that was essentially the thing that made me really, fall in love with her. Just the knowing that what we were going to create for the future of each other was going to be built off of our gifts, our talents, and then, of course, our love for each other. We had we had Anari first, and we had a midwife, we had a doula during that time, gave birth in the hospital, and it just was not the experience that we wanted it to be. So with Kari, we decided to get a midwife, also get a doula, but do an at-home birth. That was the plan. And she was fine. She was just turned 30. She was healthy. She was, we knew what the signs and symptoms were. And, we had support, family support, midwife, a doula. We had all the things in place, birth plan, everything. And her water broke, and we were getting ready to have, delivery at the hospital. But, she wasn't dilating, the way she was supposed to, essentially. So we ended up having to go to the hospital, and even that situation, that process was something that I learned, prior or after was, just the weathering of the body and just women, the anxiety of giving birth and generational anxiety of giving birth, and knowing that you were going to go into a hospital that did not serve you the way it needs to be served. So we got to the hospital, thankfully we had the C-section done during that process, though, which I also found out later was a super no-no, is that the doctor took out fibroids that she had as well. And I learned, later that, that's a whole separate other process, and I think that exacerbated her demise, just being open for that long. She ended up passing away from blood clots and showing the signs and symptoms of having these blood clots. And us knowing what the signs and symptoms were, we told the doctors, we called them daily, we had personal relationships. And, unfortunately, they were saying, just relax, just calm down, relax, put your feet up, rest. And those of you who know, that's the last thing you need to do when you have a blood clot is rest, because it moved. And, again, 13 days later, she ended up transitioning. And then, like you said, she passed on October 6th, 2019, and October 7th, essentially, we were going to make sure that, on a community level, that they knew what happened to her, how it happened, and figure out ways so that this doesn't happen.
Bruce, you want to talk about Amber?
Yeah, of course. But before I get started, I like to start my conversations with a nice Bronx warm welcome.
Okay.
And how we do that is the way that we call on each other is we say "you're" for as long as we can, most obnoxious as we can. So I just want to do a quick activity and get everybody to say that with me. I'm counting 1, 3, 2, 1.
Yeah.
Beautiful. Thank you so much. Some of y'all might be from the Bronx, but yeah, my story very similar to Omari's. Amber was somebody that I was chasing for a very long time, and she was someone that was just so focused on her goals and her education, So she was always turning me down when I was sliding them DMs. And so constantly turning me down. And in 2018, she was receiving her bachelor's degree in psychology. And I was heading back, at the time I was living in North Carolina, but she had invited me to her graduation. And I made my way to her graduation, and it was magic ever since. You know, she truly was the love of my life. And, you know, she was someone that I was really able to confide in. She was so easy to talk to and so understanding and non-judgmental. Constantly was speaking positive affirmations to me. You know, there were even times where I found myself not even being able to connect with a therapist or a counselor or a friend sometimes. But she always just had the right answer. And that did a lot for me. For somebody that was struggling with depression and anxiety and things like that, she really helped me learn how to cope and learn how to navigate through that. And so forever, I'll always be appreciative for that. And that's actually the reason why I'm here and able to speak today, is because of the man that she was building me to become and the love and support that she was giving me. Yeah, it got to the point where our love and, you know, we just felt like we were in a good space in life. So this, you know, our pregnancy wasn't something that just happened. It was something that was planned over time and we were setting ourselves up for. And, you know, September 27th of 2019, we found out we were expecting a baby, and it was the most exciting times of our lives. You know, before we even found out, you know, the sex of our baby, she's on Amazon buying all types of baby stuff. So she was just very excited to become a mother, and she would have made an exceptional mother. She would have been amazing. But yeah, throughout time, we were, you know, going to our prenatal visits. I was able to go to every single prenatal visit due to the leniency of my job. I wanted to show up and be there because it's not just her pregnant, it's our pregnancy. So I wanted to show up as her partner, and of course I wanted to make sure that she was receiving everything that she needed and to make sure that she also felt seen and heard. So I was showing up in that way, and she had known her gynecologist since 2014, so we thought we could, you know, trust her gynecologist. But as soon as she became a young, pregnant, unmarried Black woman, it kind of seemed like that care shifted. During our first prenatal visit, the OBGYN was asking us, hey, are you guys married? You know, we're telling her no, but we have plans, and she's smacking her lips and rolling her eyes. She's asking me, you know, is this your only child? And I'm telling her, no, I have other children back in North Carolina. And she did it again, smacked her lips and rolled her eyes. And after that, I realized that she wasn't really being as attentive to Amber. And it kind of felt like she didn't really want to deal with us. But, you know, Amber didn't want to change at the time because she's known her for such a long time. She didn't want to deal with anybody new. Over time, we started to notice that, you know, Amber's health is declining and it's deteriorating at a rapid pace. She's having headaches, she's feeling dizzy, and, you know, all of these things were occurring, and they're just being blown off as natural pregnancy-related symptoms. Nothing for us to worry about. Yeah, we just we weren't getting clear answers over time. Amber is someone who really took initiative in asking as many questions as she could, especially during her first pregnancy. She really wanted to understand it, but it got to the point where she wasn't getting the answers she needed, and she's buying books and things like that to read about the changes going on in her body. And the negligence was becoming so much that we decided that we wanted to look into other options. And that's when I took the initiative to look into midwives and doulas, even barely understanding what they do at the time, because it wasn't something that I was fully familiar with, but something that Amber was educating me on. And I found the perfect midwife, and we're waiting on, you know, Amber's electronic records to come through from her, from her previous visit, which there always seemed to be some sort of delay with the OBGYN, delaying that information. So we may have got her blood work maybe like a month late. And we sent that over to our midwife, and the midwife tells us, hey, unfortunately, Amber is too high risk for a birthing center birth or a home birth, and that we were pretty much forced to go back into the hospital, the medical system. And they were telling us about Amber's. She was telling us the first thing that jumped out to her was Amber's platelets. Mind you, we found out that we were having a baby. We were expecting in September of 2019. By that December of 2019, her platelet levels were already in the 90s. And we're finding this out in April. And with your platelets, of course, if they're at a 150, they need to be monitored. They drop to a 125, monitored, prepped for treatment. None of that was occurring. Her platelets were dropping rapidly. And, so she, Amber at the time, the pandemic was starting to pick up. She's trying to get early FMLA, early disability due to the changes in her body. She's feeling weak, she's feeling fatigued. She's working as an early life educator, so she's going to the school teaching young children whom are also sick. And at the time, the schools were ignoring weren't accepting doctor's notes. They didn't need doctor's notes, even though children were sick. So she was trying to avoid that because there were kids constantly coughing on her and sneezing on her, rubbing saliva on her. She's having all these pains, and she's having to constantly pick children up and down and carry them upstairs sometimes. So she's bringing these concerns back to her OBGYN, and her OBGYN tells her, well, there are other pregnant women that are working through this right now. Why should you be the exception and have early disability in early FMLA? Mind you, at this time, there were white women who were due after her who were getting early FMLA, who were getting early disability, no problem. So Amber's OBGYN denied the FMLA claims. Oh, wow. Amber took it back to her job, and we had to go through the whole process again. Amber's mother actually worked for under the same hospital branch for 25 years out of Amber's 26 years of life. So we thought we were going to be taken care of. And that was unfortunately untrue. And we had to go through the process again, this time getting her mother involved and filing complaints. The OBGYN tells us, well, the only way that you'll be able to get early FMLA, early disability, is if you see a high-risk doctor. She didn't appoint a high-risk doctor to us. She said that's the only way you'll be able to get it, and kind of just sent us along on this process. So we ended up, switching hospitals. We ended up going to the facility that her mother physically worked at, but she was receiving the same exact care as she received from the first hospital, the same exact care. We're being told we'll be taken care of. They're completely ignoring her. Her platelets are declining at a rapid pace. By the time, because we're due in May, we're told. We're due in May of 2020. But after the midwife made the claim and we kept bringing that to their attention, that's kind of when they were scrambling around to try to help her, because they realized at that time it was becoming too late for her. And that they had to step up and do something. So by the time we got some blood work done, delay in the blood work, there were multiple physicians signing off on Amber's paperwork as if everything was fine, but a midwife was able to tell us exactly what was going on versus everybody who was looking over Amber's paperwork. So they seen what was going on with the blood work. By that time, they had seen it. Amber's platelets were already in the 40s. I believe it was a 46. And they called us into the hospital the very next morning on April 18th of 2020, told us to come in for examination and treatment. And that's all we were supposed to be in there for. Amber ended up having to stay overnight, which she was scared of because she was someone that took care of her health. She never had to stay. She was one of the most healthiest people I've ever known, so I truly don't understand how this happened. Where she's having to stay the entire weekend until they figure out what's going on with her, because nobody could really give us an answer. Well, she may have COVID, she may have preeclampsia. She passed 3 COVID tests They all came back negative. It's like they were trying to push COVID so they would escape accountability. And yeah, they allowed me to finally be in the room with Amber after advocating for her and her advocating for me to be there, because at the time, partners weren't allowed to be in the rooms, midwives weren't allowed to be in the rooms, no type of support. And, you know, that was something that she needed. And I remember when we got to the hospital, as a concerned father, I'm telling them, like, hey, I need to be upstairs with Amber. She's scared to death. And this is no fault of her own. You guys have done this to her. I get called out of my name by the security. Well, okay, Mr. Baby Daddy, she's gonna be just fine. You need to go sit down. Matter of fact, we don't want you sitting down in the lobby. Wait outside. You can wait outside in your car, and she will text you for updates. That's the treatment that I got for being a concerned father. I didn't raise my voice. I was just concerned for my partner. So during that time, they didn't know what was wrong with her. She finally texts me on April 20th and tells me that they found out it was HELLP syndrome, HELLP syndrome, which is a heightened elevation of your blood and liver enzymes. Her blood was not clotting, and her blood was becoming more and more and more water-like throughout time. They told us, you know, well, here's what we have, here's what we can do. Cesarean section being the very, very last. They leave the room, come back maybe 30 minutes later and tell us our only option is a cesarean section. And they pushed Amber into the arms of irrational decision-making to where she had to say yes. It was her only option. Set me in a room, they say she'll be back in 20 minutes. I'm talking to Amber, trying to motivate her to stay positive. Especially because we only thought we were coming in for treatment, to find out that we're giving birth 40 days prematurely was very scary. And I'm telling her, well, this is it. We're going home after this. And, you know, the last words from Amber to me were, yes, all three of us are going home. All three of us are going home. And she kept repeating that to herself as she was wheeling out, and she was breathing frantically. She was panicking. And they told me she'll be back in 20 minutes. Hours go by, I'm not hearing anything. Nobody's telling me anything. I'm asking all types of questions. I finally see a baby coming out of the ER, or the OR, and I realize it's my son. And then I hear them calling over the intercom that they need all emergency personnel to rush to her room. I see doctors running out of her room, rushing to the other side of the hospital to grab pints of blood. They clearly weren't prepared for this at all. You know, I spoke to this black nurse, and I'm asking her all types of questions, and she was the only one that would confide in me, or that she was the only one that would answer my questions. You know, I'm asking her, I know that she had a C-section. Did they sew her back up? How is she? I see her choke up. And she tells me, no, they had to cut her open a second time. For what? They tell me they didn't know where the bleeding was coming from, so they removed her uterus. They performed an emergency hysterectomy while her platelets were very low. I'm telling them, well, Amber's going to be pissed because we just discussed having a second child. And they just removed her uterus just for them to tell us that's not where the bleeding was coming from. So they performed the hysterectomy for no reason. Then I asked, well, did they sew her up after that? She says, no, they had to cut her open a third time. They cut her chest open and manually massaged her heart for over 3 hours. That was it. They weren't trying to do anything to raise the platelets or anything. So after she's leaving, I see a bunch of doctors leaving the room, a bunch of white doctors that are leaving. They're patting me on my back. You're gonna be okay. Everything's gonna be fine. You're gonna be all right. As they get to clock out and they get to go have dinner with their families and spend time with their families. And I'm thinking, you know, just by that little bit that they gave me, I'm holding on to a little bit of hope. Then I see a group of black doctors leaving the room, and I can just see it in their faces that they were just so upset. To where they couldn't even like look at me. And Amber's head surgeon that never showed up for her, passed her down to a much younger team, finally shows up after she passes away to try to break the news. sees a room full of black folk, turns around, grabs a colleague, and comes back to break the news to us to tell us that Amber did not make it. And then I'm told that Amber was no longer alive to attest that I was the father. So they made me go through this whole process to prove that my child was mine, on top of grieving. They had to pass my son down to the next of kin, which was really me, but they passed it down to Amber's mother. He had rights to my son for a while. I had to fight for that, but luckily Amber's mother and I were already really close. During that time, also, while I'm stressing, through all that stuff, I'm having to plan for a funeral now. The hospital sent me a bill for $2,000 for the delivery of my son. And they told me that on the paperwork, they were trying to send Amber's body to Hart Island, which is an island that is a mass grave for where they were dumping COVID bodies. They wanted to put Amber there even though she didn't have COVID. And I had to raise $30,000 in a week to give her a proper funeral, which I did. And that kind of activated my advocacy work. Yeah, it's been really tough. It's been really tough having to go through that, and to just know that the system wasn't there to help, and that they were just making things worse instead of, giving us what we needed. They weren't, the therapists that they gave us weren't even giving us the proper evaluations, but they were quick to try to throw drugs in our face, like Xanax and other antidepressants. And I'm thinking to myself, this is such a perpetuated cycle that we see in underserved communities where they have to they gain some kind of dependency on these drugs, and then they become addicted, and then, they're incompetent to raise their children, and then they, CPS, and then it's just a whole system. But luckily I was able to have midwives and doulas in my corner who offered me, free grieving counseling and all types of things, holistic things that ended up benefiting and working for me in the end.
Thanks for sharing that, both of you. So Omari, we saw in the documentary where you actually reached out to Bruce right after that and to offer support in his grieving process and to collaborate with him to find solutions and to create programming and opportunities for other men to be supported and to actually be engaged and to be active in trying to address this crisis. Can you talk about that, about how you sort of built those networks and those support circles?
Excuse me. So the statistics state that Black and brown women pass away about 600 to 800 women pass away every year due to maternal mortality issues, inadequate health care. Thankfully, Shamani passed away before COVID, right before COVID. So I was able to be in the hospital with her and be able to, live through the entire process of, celebrating her life, but also watching her transition and being with the family. And after she passed away, and then I, was able to do some research, learn about the numbers and statistics, I just knew, there was a men's group with fathers getting together around the country that, was dealing with the same things, that we could start, mobilizing and being active. But I quickly found out that there was not. Thank God for social media, because once, she transitioned and then her story started to kind of spread, there were two specific gentlemen that reached out to me. One was Mustafa Sabaz, and the other one was Charles Johnson. And they both lost their partners the same way that, Bruce and I did. But in them reaching out to me, and then being able to have these real conversations with them, like these are two total strangers. And for both of them, I was on the phone with them for multiple hours, just really having deep conversations that I've never, and I couldn't have with my mother at the time, my family at the time, my closest friends. Even though they were there, they were supportive, there were things that they just wouldn't understand in the questions that I would ask, wouldn't know how I felt. And, more importantly, wasn't really sure if I can confide in because I didn't even really understand what my mental, emotional, physical, spiritual state was at the time. So really having that opportunity to touch base with men who experienced the same things as me, I knew that, when the time came, I wanted to pay that forward because I knew how much of a help it was for me just in the day-to-day. Because when you're dealing with that type of loss, and Bruce didn't mention this, but, I had to bury Shamani, on my birthday, and when I reached out to Bruce, I'm telling him my story, and he's like, man, I had to bury Amber on my birthday. So once I heard that, like I understood, one, that we were in the space, fortunately and unfortunately, that we were supposed to be in. This movement, these feelings, this thing that we experienced in trauma and grief and loss was way bigger than the both of us, and that it was important to be able to create systems for BIPOC men specifically to grieve, to process information, to understand what trauma is, to understand what emotional bandwidth looks like when you're able to go through and have conversations with, men that you feel comfortable with on a day-to-day basis. And, that was kind of the precipice of what I have now, which is the Luxor Collective, which is a support group for men who's dealt with maternal health, mortality, morbidity, trauma and grief, and healthcare inequities around the country. And it's a virtual group as well. So, we get together every other Thursday and have these real conversations. But I knew that, for us, and me and Bruce, that this was a journey that we were going to have to take together. And thank God that I've got Bruce, because, like you said, this isn't easy, but to know that, there's somebody who's lockstep with you, and even if we're not speaking every day or engaging all the time, I know in the back of my mind that the days that I don't feel like working, Bruce is out there doing the thing, so I need to go out there and do the thing, and vice versa. And that's exactly what the support group kind of creates, is this momentum building and this shift in understanding that, especially in this maternal health space, that we're all doulas and doulos, essentially, because our grandmothers, our great-great-grandmothers, that's what we did. So it's innate within us, but it's important to understand that in this day and age, especially for men, that we can't necessarily just sit outside the hospital room because before we knew our aunts, our sisters, our mothers, our grandmothers, they were going to take care of it. But, we have to make sure that we're creating spaces and pathways for men to have basic knowledge about what's going on, during the gestation process, during the delivery process, and more specifically postpartum. Even if you have an excellent, beautiful, awesome birth, you're going to deal with all the things that come postpartum because there's an entire shift that happens in your own life and in your familial unit. So that was the reason why. The reason why I started the group, like I said, is because of Bruce and Mustafa. But doing this for a while now, the bigger understanding is that in order to be able to really shift maternal health outcomes, we have to really be able to support each other and create, again, different pathways, different avenues in order to see that support happen.
Excellent. So is that the main thing you've been doing with ARIA Foundation, or you have some
No,
other?
there's a thousand things that ARIA is up to right now. So the ARIA Foundation is a foundation that I co-created with Shawnee Gibson, which is Shamani's mother. ARIA stands for the Advancement of Reproductive Innovation Through Artistry and Healing. I am a visual artist. Shawnee is an artist herself. She's an author, she's a dancer, she's an orator, she's many things. But we understood the power of art and the power of art and advocacy and revolutionary movements, right? So that's the reason why we created ARIA. So ARIA has the Luxor Collective, which is the men's group. They also have, we also have the, Remembering You, Remembering Us, was a support group for families who are, in this maternal health, healthcare inequity space. But we also have a couple of different conferences and events that we do. One is called Speak, Move, Change, which there's flyers on the table in the front for. So Speak, Move, Change was started by Shawnee, Wanda Irving, and Maddie Oden. These three women lost their daughters to the maternal health crisis, and as mothers, put a collective together called Speak, Move, Change. And now ARIA is essentially pushing the Speak, Move, Change movement. So our next event through Speak, Move, Change is the Reproductive Freedom Train. So very similar to the Underground Railroad. There are so many people doing so many amazing things around this country. But in order for us to be able to close this gap, we have to make sure that we're highlighting the people from the present, people from the past, and specifically what we're going to be doing in the future to really change healthcare outcomes. So the Reproductive Freedom Train is just that. It is a system where we're going to different people, different organizations around the country and highlighting people like Jenny Joseph and highlighting institutions like Mama Toto, different institutions around the country, so that in a very edutainment way, you know, where it's palatable, it's informative, and more than anything, you can understand and get all the resources that you need in one spot. And it's a virtual event, a 2-day virtual event that we're doing in April. And then we have a Postpartum Awareness Week, which is the week leading up to Mother's Day. We understand the importance and how effective Black Maternal Health Week is and was, but we're losing most of our women during the postpartum period. So we wanted to make sure that we created a week virtual sessions where we're bringing in experts, thought leaders, storytellers, dance, movement, all the things, to create an event where you're learning all things postpartum, right? So from nutrition to where you can find resources, to men's groups who are supportive, to you know, edifices and how architecturally, you know, it's important to create spaces for maternal health to happen properly, you know, and yeah, this is going to be the 4th year that we're doing it. There's also flyers in the front for that as well. But, you know, those are just a couple of the things that, you know, we're doing. But the focus is always on information, education, entertainment, art, and artistic modalities.
That's fantastic. I love that. And Bruce, you have been engaged at all the levels, at the community, state level, and the federal level, and trying to move systemic change. Can you talk about some of your activities that you've been working on to move this needle?
Of course. So I've been blessed to be able to work with state legislators on pushing the needle forward and for maternal health and protecting Black families and creating better birthing outcomes. So very grateful for that. I'm actually a part of the New York City Council Maternal Health Steering Committee as well. I hold a chair there, so I'm able to, you know, oversee some of the budget and have a say-so on the budget, which is also nice. I've been blessed to educate students. I've been able to teach accredited courses to medical students throughout the country on implicit bias. And I've been, you know, getting a lot of great feedback for that, and I think it's very important that we do reach those, you know, those residential learners who are coming into the field, because, you know, we ultimately are learning from a racist practice, and we have to kind of like unpack that. You know, a lot of people are ask me all the time, you know, how can we get, you know, people to trust the system again? And the simple answer is we can't. It's too late. And the only way that we're going to be able to do that is if we completely reimagine this system to create something better that benefits everyone, no matter your color or creed. Yeah, so I think that's the only way that we're going to be able to really push the needle forward. Unfortunately, and it's going to take a lot. It's going to take a lot of hard conversations. It's going to take a lot of education. It's going to take a lot of unlearning and relearning. Yeah, so and my biggest push has also been for, you know, birthing centers. I'm currently trying to open a birthing center, and you'll see it in the film as well. I've been working on that since 2020. I joined the the Birthing Center Association of New York, and we passed the birthing center bill that would allow midwives to operate a birthing center. However, the governor completely gutted it from what it was supposed to be, and the intentions behind it. So we're constantly having to go through these hoops and whistles and all these things. So many barriers. And, you know, it's something that we personally can't wait for because this is a problem that's going on now. And so we took the initiative, my partner Myla Flores and I, we started the Womb Bus program, which is it's a big pink Sprinter van that services 5 areas of the Bronx where we see the highest mortality and morbidity rates. Sometimes we spread out to other areas of the city like Brooklyn or Staten Island, Queens on occasion. And we offer access to midwives, access to doulas, access to chiropractors, acupuncturists, people who do Reiki. You know, all of these holistic healings is what we like to offer the community for free, because we really want to make a difference. We also 6 months ago just opened up a women's health clinic called Miriam Reproductive Health and Wellness. We named it Miriam after the Miriam flower that midwives used in Africa to help induce labor. Until we can get this birthing center. And, you know, we were lucky that we found a unicorn in this maternal health space. Our director is a OBGYN who respects and follows the midwifery model of care. And so we're able to pass our CPM bills, our certified professional midwifery bills, so they could operate in New York, you know, without any problems, because that's essential. It's something that we truly need for, you know, I believe that women that aren't high risk should be seeing a midwife. They should be seeing a doula. I truly believe in that model of care where you're being taken care of before, during, and after pregnancy and throughout your postpartum period. Like, I think that is something that is essential to birth right now, you know, especially for Black and brown women where, you know, the access, we haven't had that access like that. We're constantly trying to push for insurance companies to cover out of hospital births. That way, people aren't paying so much out of pocket because truly, you know, being seen by a midwife is cheaper. But since insurance will cover a hospital birth, you're paying more out of pocket, and a lot of people just don't have that. So, you know, constantly trying to create scholarship programs that'll cover, you know, midwifery care, that'll cover doula care. New York just expanded their doula coverage. But it's not enough. We need more. We definitely need a lot more equity in these spaces. I also, in a lot of these conversations, I hear a lot about, you know, data. Data is fine and all, but data can also be manipulated, which is something that's happened to myself and it's happened to Omari. You know, Amber's her high-risk doctor was actually the one who performed her autopsy versus a medical examiner who really should have seen it. So that's, you know, that's a red flag right there because they're able to manipulate and say what they want to say on their sheets. The same thing with Omari. They were trying to say that, you know, Shamani was obese, which wasn't true. She just had a baby. So, you know, data can constantly be, you know, manipulated, and I think it's also very important that we're collecting data from community organizations who are also keeping up with that data, and I think we should exchange data and really create a database where it's coming from, you know, the hospitals, but it's also coming from the midwives, and yeah, I think that's just very important. I would love to see, you know, more birthing centers throughout the state, in the rural areas, as many as we can. And I think equity is really the factor in it, and, you know, making sure that we're funding organizations that are, you know, that are prioritizing that. It's time that we get rid of that assembly line model of care and create more personable care for people. And I think that's exactly how we're going to get it done. So that's been my mission to, you know, to try to move the needle forward.
So on that note, Bruce, what do you hinted at it a little bit, and I don't know that I got all of it, but in terms of what needs to happen from a policy point of view, or whether it's regulatory point of view, what needs to happen in order for more birthing centers to be the norm?
Yeah, so making sure that any birthing center bill in the states are supported, making sure that we have CPMs that are practicing, that are able to run their own practice, truth and reconciliation from the hospitals. I think it's something that's very much needed. And also making sure that we have, I believe Washington already has it, but making sure that we have wrongful death laws set up in place. I'm also one of the founders of the Justice for Grieving Families. New York State doesn't have a wrongful death clause currently. And it hasn't been updated in 188 years, back when Black people weren't even in mind. And there are only 2 states that don't have a bill like this in place, and that's New York State and that's Alabama. The 2 only states in America that don't have a clause like that set up in place. So I think it's very important that we have these wrongful death clauses, that we're holding these hospitals accountable for their actions. And I've been trying to get this bill passed, the Grieving Families Act passed since 2021. And it's been vetoed 3 times, but it's unanimously passed through Senate every single time, and to the point where they want to introduce it for a 4th time. Usually after the 3rd time, it's kind of over with. But our state representatives really believe in this bill so much that they want to get it pushed for a 4th time. So I think that's very important, because how is a bill like this seen as a threat? How much of a threat is a bill like this seen, to be a threat to the hospital's financial stability? Like how many lives are being taken wrongfully? How many women are going neglected? And I think, making sure that we have laws like that set up in place is a way that we can set up accountability for these bad actors that are setting trends. Also, I don't believe that, we should be sending these doctors that are setting trends to other hospitals. We're dealing with a situation now who there is an OBGYN who has failed and let down 3 mothers. 3 mothers have died under her care. And they're getting ready to transfer her from Brooklyn to the Bronx, to my borough, where we already have the highest mortality and morbidity rates. In the Bronx, you're 14 times more likely to die during pregnancy-related outcomes. In Brooklyn, I believe it's 12 times more likely to die than your white counterpart. Queens, 10 times, and I believe Long Island or Staten Island is 8 times. In our city, and and that's also coming from the spike in C-sections as well. We've seen a 500% increase in C-sections in underserved communities since the 70s, and that's also something that I hear a lot about. Oh, we don't have the technology. Well, we didn't have the technology in the 70s, and we were having better birthing outcomes then. My grandmother had, a better chance of giving birth back then than we do today. And that, to me, is completely outrageous. Like, where is the funding going? What policies are we setting up in place that are really holding people accountable? Because, malpractice insurance is really kind of saving people. And it's really putting that barrier of accountability, so it's kind of their way to avoid accountability. They come to our underserved communities that are Black and brown, that have, a lot of these families have been pushed into these neighborhoods due to segregation. Where I heard earlier, we're not getting the nutrients that we need because we're getting bottom of the barrel in our neighborhoods. And we're not getting, the things that we receive. So it's definitely an economical factor as well that plays in place in maternal health as well, and trying to sustain a healthy birth.
All the social determinants. So I'll ask this question of you, Mari. It's coming from the audience. What advice would you give to expecting families, specifically the fathers, who may have to advocate for their partners? Well, as you both did, what advice would you give?
Yeah, so I would definitely tell fathers, really in every family, you have to have a birth plan. There has to be a birth plan that's in place. There has to be a birth plan that's in place that all the family members know about. And they all have to know what their role is within that birth plan. The thing about information and education is that everybody doesn't have to know everything, right? And we want to create a system where the community can support you, but you have to be able to let the community know how they can best support you and based on your needs. That's one. The next thing is that, and this is coming from a brother's name is Onaje Muid, call him Baba J, Dr. Onaje Muid, excuse me, but he states that you need the team, and the team needs to be a doula for the mom, a doulo for the father, somebody who can move and inform the father through, the postpartum awareness period, postpartum period, a lactation consultant, and a midwife and doula, and I said doula already, but and a midwife. And that could be the basis of what your team is. If we can create that type of team for all families around the country, then there's no way that there won't be better outcomes. Because again, you're creating a team that is informed, knows their role and knows their place, and understands what they need to do and how they need to serve their partner. The birthing partner, as well as who's supporting that partner. So those baseline, that's what you need. Yeah.
So right now, in terms of those kinds of resources, they're not free most of the time.
Yeah.
Right? What is the status of payment for that through insurance or Medicare? Or
Yeah,
any of
so
those?
thankfully, I think Aza talked about it earlier. Some is covered under Medicaid. A lot of it would have to be out of pocket, unfortunately. But when you have a birthing plan and we have a system in place to have a plan, then you create the things that you need through whatever the resources you have in terms of saving or asking people and asking community. And I know also that's also not always feasible for people, but just knowing what the information is. When I tell people also too, if you're going into the hospitals and you don't know what you need to know, you need to at the very least know what the language is, right? And that could be just as simple as saying, yo, I saw aftershock. I don't want that to happen to me, right? So what are the things that we can do in order for this not to happen to my family? Once people are informed or know or think that you know something, then the treatment becomes very different. The interactions become very different. But you have to be able to put yourself in a position where that knowledge and information is being, outputted so that people understand, where they need to meet you at, But and then also too, we talk about, convenience and, especially, with care. If you're going into a hospital, just because it's the closest one to you doesn't mean that's the best one for you, right? Just because your doctor or your nurse is Black does not mean that's the best person for you, So understanding that you have autonomy over all of these things, you can move, you can act, you can shift, being able to put more outliers like that so that people can be more well-informed, I think will be small shifts that can create big outcomes.
Excellent, great, fantastic. So there's another audience question. I guess we're gonna have to wrap up after that. Okay, this is the last question. What advice what is your vision for what the future of Black birthing would look like? You wanna start with that, Bruce?
Yeah, I think to me, it's birthing centers, where, I feel like women are being seen. So I know that we all hear the phrase, like, we should treat everyone the same, but I don't think in the medical system, I don't think that's true. I don't believe that we should be treating anybody the same. I believe that we should be creating personalized care that is tailored to their needs. And I think that midwives are the solution for that. I hear a lot, about midwives, a lot of bad, negative things about midwives. But what we've been doing hasn't been working. So, why shouldn't we try something new where in other industrialized nations we're seeing better birthing outcomes? People are, they go straight to midwives if they're not high risk. And I believe, by seeing a midwife, they also teach you how to avoid, becoming high risk, and they really guide you from point A to point Z. Versus, in the hospitals, I kind of feel like we're just getting that assembly line model of care, get them in, get them out, and not really building the rapport that, that we need to feel comfortable. So I think that's definitely essential, and to me, that's the future of creating better solutions.
Mari, did you have something you
Yeah,
wanna add?
so mine looks like just people utilizing birthing options. There being more spaces like a birth center, like at-home birth, like the knowing of going to a hospital and have a water birth at a hospital, going to hospitals that have midwives and doulas on site, having men more involved, and creating pathways where this type of information is being shared to people outside of the birthing community. Like, we talk a lot to midwives, we talk a lot to doulas, doctors, nurses, healthcare, insurance people. They all know what's going on. We want to talk to people who don't know what's going on, and how you reach those people is through entertainment. To me, it's through the power of television, the power of film, the power of photography and painting and those type of mediums, to be able to help shape, from nation or nationally, or even globally, how we think about birthing and how we think about our models of care and our systems of care. And then lastly, too, is, we know what's working. It's working overseas. They have midwives and doulas are integral parts of birth. You don't go to a hospital and give birth and they not be a midwife and doula there. They have to be there. So I think more than anything, so what we're doing as a foundation, as well as we're working with an organization called Bumi Sahat, who's located in Bali, Indonesia. And out there, we're going out there over the course of the next 2 years to learn what their birthing practices are, so that we can get that information and bring it back stateside, and we start to implement it and utilizing it in different models of care of what we want to see, and have it disseminated through hospitals and other people who are visionaries in that way. But I think that's what we have to do. We have to go to the source of people who understand what works, understand how it works, and utilize everybody. I know this is a very interesting climate that we're living in today, just with the whole shift in regime and a lot of government spending being cut and a lot of things just shifting. Like, things that we knew to be last week are just not what it is today. And I think that, unfortunately, it's created a lot of turmoil, but out of it, the silver lining is that I think there will be a lot more individual care. I think there'll be a lot more opportunities for people to understand who they know they need to deal with, who does not have their best interests in mind. And then when you have those type of things that are pushing you, then when it's really life or death, you start to, you'll figure it out. You'll figure it out. And I think that in that, different pockets of community learning through different pockets of community building will occur. And in those places, we need to make sure that we're modeling it throughout the nation, so that we can really start seeing the shifts that we want.
I really appreciate that. As a communications person, the thing that comes to mind for me in thinking about framing the future of birthing in America in particular is thinking about the idea that if we actually address and improve the situation for the most vulnerable populations, we actually make it better for all the populations. So if we are really driving the idea of the solutions that you all were talking about in terms of birthing centers and home births and all the different ways that are more holistic, and we make that a thing in the United States that then becomes accessible to everyone, maybe perhaps it's something that could gain some traction, because we live in a society, unfortunately, where people are thinking about what matters to them, how they're impacted. And so I think if we look to frame it in a more universalist sort of from that point of view, we can maybe also, that can maybe also another way to move the needle.
Definitely.
Yeah, but I appreciate you all. We're going to wrap up. I need to do a few acknowledgments. Thank you, Bruce and Amari, all the researchers, policymakers, and advocates who have made this day possible. For all of you all who have made us more knowledgeable and hopefully more interested in making maternal health health equity real in this country. I would love to thank my colleagues at Policies for Action who put a great deal of thought and work into this day. Thank you to the Robert Wood Johnson Foundation for their generous funding and solid support through this whole process we're going through right now in this season that we're in this country. And thank you to all who showed up here in person and those online. Many of you are working very hard on this issue in your own spaces, and or you may have brought a spirit of curiosity that is extremely important and valuable for moving the needle forward on this issue. So we hope those of you who are here with us in person will stay for a little while. We have some refreshments. We have some time to network and connect and continue the conversation. And with that, we'll wrap up this event, and I thank you all for all of your support.